ngapun luhur jauh di awang-awang, bebenjang jangna bangun ayah karinda, kuku narang raos rejempang matur nangeluh, ngepak mega beri hibernar tarik burungnya. Manuk dadari, manuk panggagana, lambang sakti Indonesia Jaya. Manuk dadari, pangkal kocarana, beserta hiji, rukun sakamera, duduk-duduk cucuk kembelengan, minum jiwa pukul kembelengan, wakul limpang segadinda.
Selamat datang di Departemen Fisika, Fakultas Sains dan Teknologi Universitas Airlangga. Departemen Fisika didirikan tahun 1982. Departemen Fisika memiliki 45 staf pengajar dengan 1 orang bergelar profesor dan 6 orang bergelar S3, sementara sisanya berpendidikan S2.
Departemen Fisika memiliki 3 program studi S1 Fisika, program studi Teknobiomedik, dan program studi D3 Otomatisasi Sistem Instrumentasi.
Departemen Fisika mempunyai 6 kelompok bidang keahlian, di mana kelompok keahlian tersebut terbagi ke dalam 3 program studi, S1 Fisika, Teknobiomedik, dan D3 OSI, KBK Biophysics, KBK Fisika Material, KBK Fotonik, KBK Fisika Teori, KBK Komputasi, KBK Elektronik dan Instrumentasi.
Departemen Fisika memiliki beberapa laboratorium sebagai penunjang proses belajar mengajar. Selain untuk proses pembelajaran, laboratorium tersebut juga digunakan sebagai tempat menyelesaikan skripsi mahasiswa, baik program studi S1 Fisika, Teknobiomedik, maupun program studi D3 Otomatisasi Sistem Instrumentasi. Laboratorium Fotonik. Laboratorium ini mengembangkan aplikasi laser baik untuk bidang industri maupun medis. Laboratorium Biofisika. Laboratorium ini mengembangkan aplikasi fisika dalam bidang medis.
Elektronik dan instrumentasi. Laboratorium ini mempelajari dan mengembangkan elektronik dan sistem instrumentasi untuk industri dan medis. Laboratorium ini mengembangkan material logam, polimer, keramik, dan komposit, baik untuk industri maupun biomaterial medis.
Laboratorium Fisika Modern. Laboratorium ini digunakan sebagai sarana praktikum dan penelitian yang terkait dengan fisika modern, antara lain pengukuran radiasi dan tomografi. Bengkel mekanik dan gelas. Melalui bengkel ini, mahasiswa dilatih untuk memilih keterampilan yang terkait dengan penggunaan bor, gerinda, bubut, dan sebagainya. Laboratorium Elektronik Medis. Melalui laboratorium ini, mahasiswa belajar memahami sistem instrumentasi medis dan penggunaannya. Departemen Fisika telah meluluskan sekitar 650 alumni yang tersebar di berbagai bidang pekerjaan, antara lain ada yang diperbankan, ada yang menjadi dosen dan peneliti, ada yang berwira swasta, dan ada juga yang bekerja dalam bidang industri.
Dengan saya kuliah di UNER, terutama jurusan OSI, banyak sekali ilmu yang saya dapatkan untuk menunjang dunia pekerjaan saya sekarang. Misalkan saja PLC, mikroprosesor, mikrocontroller. Semua ilmu-ilmu yang saya dapatkan di OSI sangat bermanfaat dan berguna untuk menunjang dunia pekerjaan saya di bidang PLN, di bidang kelistrikan ini terutama.
Kita ketahui bahwa Universitas Airlangga adalah salah satu universitas tertua di Indonesia Timur yang kedokterannya begitu berkembang pesat. Mata-mata kuliah yang mengandung fisika kedokteran harus dikonsen pada mata kuliah, satu contoh anatomi, fisiologi kedokteran, radio imaging, tentang pesawat, fisika radioterapi, yang itu akan nanti mengaplikasikan model di bangku kuliah dengan aplikasi di lapangan. Fisika dapat berkembang di bidang kedokteran. Harus dilakukan adaptif pada kurikulum sehingga dia lebih mengena pada aplikasi di dunia kedokteran. Saya kira itu.
Akbar. Assalamualaikum warahmatullahi wabarakatuh. Selamat malam. Salam sejahtera untuk kita semua. Salam. Om Swastiastu. Namo Buddhaya. Salam kebajikan. Good day to all of you. Firstly, we would like to greet our special guest here. Welcome to the Honorable Professor Yasin, Dean of Faculty of Science and Technology, the Honorable Mr. Supri. Health. The Honorable Professor Suryani Diah Astuti, Head of Master Degree Program of Biomedical Engineering from Universitas Airlangga. The Honorable Professor Dr. Suhariningsih and Madam Nurul Fitriah MSc as our moderator. And also to all of the participants, ladies and gentlemen, brothers and sisters joining the webinar series from AFISMI, Aliansi Fisikawan Medik Indonesia, or Indonesian Association of Physics and Medicine from all over Indonesia, university students, lecturers, and researchers from, I will mention several institutions in our list here, both state and private education board, namely UNER, Brawijaya, UI, ITB, IPB, ITS, USU, Undip, UNUSA, UNS, UNAS, UNILA, UNSRI, Politeknik Kemenkes, ITERA, Hasanuddin, Mula Warman, San Pedro, and alumni from Philippines, Thailand, and other countries. Also, public attendee from hospitals all over Indonesia, clinical and medical enthusiasts. My apology if we cannot mention all the institutions due to time limit. Alhamdulillahirabbil alamin. Praise the Lord. Because of His grace, we can still gather here to gain knowledge from these extraordinary speakers, even though it must be done online. Hopefully, we can keep our spirit for learning and staying healthy. We are really excited to have this webinar as we can collaborate with national and international team. This event is the fifth webinar series of world-class university program held by the Department of Physics, Faculty of Science and Technology, UNER. The theme of this webinar is Current Research of Biophysics and Medical Physics. Herewith, I will describe the timetable. First, opening. Second, singing the song of Indonesia Raya and hymn of Universitas Airlangga, followed by hymn of AFISMI. Third, opening speech from Dean of Faculty of Science and Technology UNER, Professor Yasin, followed by opening speech from Mr. Supriyanto Arjo Prawiro, MSc, PhD, Head of AFISMI, Chair of AFISMI Head Office. And next, saying the prayer. Then, our main event, lecture and presentation with discussion and Q&A session with our four outstanding speakers. Continue to the next agenda, singing the song Indonesia Raya, hymn of Universitas Airlangga and AFISMI. Please the committee to take over control. Thank you.
Timur Jawa Dwipa, megah engkau bertahta, Satria air langga, kusuma negara. Dari engkau ku dapat budaya pusaka, air langga di kau permata, Indonesia Raya. Bagimu alma mater, ku berjanji setia, berdharma bakti suci, berjasa mulia. Belajar untuk nusa Indonesia yang ku cinta, air langga kau hiduplah, air langga tetap kau jaya.
Bergerak serentak menuju kejayaan, fisikawan milik Indonesia, akurat dan presisi, minim deviasi, itu cita kami. Kie-kisi, sepi radiasi, itu tugas kami. Mari kita bekerja untuk nusa bangsa, semoga Tuhan melindungi. Kie-kisi, sepi radiasi, itu tugas kami. Mari kita bekerja untuk nusa bangsa, semoga Tuhan melindungi.
Thank you. Next, the opening speech. The speech will be delivered by Professor Yasin as Dean of the Faculty of Science and Technology, UNER. Please welcome Professor Yasin. The virtual stage is yours. Mohon maaf, Profesor Yasin. For the opening speech, the speech will be delivered by Professor Yasin, the Dean of the Faculty of Science and Technology, UNER. Please we welcome Professor Yasin.
Okay, because you mute my Zoom. I cannot speak. Thank you, Miss Chairman. Ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Good night to other five and good morning for our speakers from United States. Praise to be our gratitude for the presence of Allah Subhanahu wa Ta'ala who has given his grace and guidance so that today, on Saturday, November 14, 2020, World Class University webinar with current topic of Biophysics and Medical Physics, organized by Department of Physics, Faculty of Science and Technology, Universitas Airlangga, in collaboration with Indonesian Medical Physicists Association, FISMI, can be carried out well and smoothly. We would like to thank the chairman of Central FISMI, Dr. Supriyanto Arjo Prawiro, for his presence and support at this webinar. Hopefully, this collaboration can be continued in the future. Many thanks to Professor Cheng Shao, Director Northeast Radiation Oncology Center and NROC and Thomas Jefferson University. Professor Tian Hong Day from Harvard Medical School, Professor Douglas Pfeiffer from the Boulder Hospital and University of California, who have been willing to become speaker and share development of knowledge in biophysics area like photodynamic therapy, radiotherapy, and radiodiagnostic. Hopefully, this collaboration will be continued in the future in the form of academic release, joint research, and joint publication. My gratitude also goes to my colleagues, lecturers, researchers, and students from various institutions, as well as FISMI members from all over Indonesia. Welcome to Universitas Airlangga. I hope this webinar will become a forum discussion and add insight for all of us. Distinguished guests, this webinar activity is one of the world-class university activities of Universitas Airlangga. As we know, the current So it's hoped that every higher education institution in Indonesia can position itself in the rank of the world-class university. One of the indicators towards a world-class university is the implementation of international program at higher education institution. As one concrete step that can be taken is exploring the possibility of cooperating in the implementation of education with international education institutions. Airlangga University is one of universities appointed by government through Minister Research, Technology and Higher Education to become world-class university to pursue 500 rank in 2019. Universitas Airlangga need not only international cooperation for the development of teaching staff, but also required institution recognition through student and lecturer exchange program, joint research, double degree, joint degree program with partner university abroad. This webinar was attended around 500 participants, but around 1,000 registered in this webinar for various professions, both domestic and international. The implementation of this webinar is expected to increase partnership cooperation in education, research, and publication with domestic and international institutions. We would like to thank all committees from Department of Physics, including lecturers, staff, and students, and FISMI for their cooperation and support so far from the initial stage to the end of the webinar. Hopefully, this togetherness will always be maintained in the future. It is our hope that this webinar is a milestone for initial friendship, discussion, and collaboration of all lecturers, researchers, clinicians, stakeholders, and students to build synergies and solutions and supporting the progress of independence of Indonesia nation. With this synergy and solution and supported by motto excellent with morality, the contribution of physics and its application in the medical field will be even more real for this beloved country. Physics is beautiful and extraordinary. I hope we can all explore it. Have a good webinar. I hope this webinar will make a positive contribution to all participants. May Allah subhanahu wa ta'ala always guide us to do our best at every step of the way. Always success. Wassalamualaikum warahmatullahi wabarakatuh. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Professor Yasin, for the speech. For the next session, the opening speech, Chairman of AFISMI Head Office. Please we welcome Mr. Supriyanto Arjo Prawiro, MSc, PhD. The virtual stage is yours. Monggo untuk Pak Supriyanto.
Can you hear me?
Yes, please, Pak.
Okay,
We can hear you.
okay. Thank you very much. Honorable the Dean Prof. Yasin, as the Dean of Faculty of Science and Engineering, Airlangga University, Head of Department of Physics, and also faculty members of Airlangga University, Professor Cheng So, Professor Douglas, Professor Tian Hong, and Professor Suryani Diah as invited speakers, Professor Rin, Suarningsih, and also Ms. Nurul as moderators, Chairman of the AFISMI chapter of East Java, Bambang Haris, Professor, distinguished guests, students, AFISMI members, and participants. Assalamualaikum warahmatullahi wabarakatuh. Good evening for everyone. First, thank you very much, Professor Yasin, Dean of the Faculty of Science and Engineering, for inviting me as the chairman of the AFISMI to give the welcome address to this event. I'm delighted that continuing education, medical physics and biophysics in these years is increasing rapidly, especially via webinar tools, via Zoom. And I appreciate much to the Dean of Faculty of Science and Engineering, and also the medical physics and biophysics groups, and also AFISMI East Java, who organized webinar with the current title is Research in Medical Physics and Biophysics. For your information, that the medical physics has recognized by the government as the health professional since 2007, and continue with the recognized by Ministry of Manpower and also the Nuclear Regulatory Agency and also the government since 2014 by issuing the medical physics include in Health Professional Government Act. However, we still struggle with the harmonized medical physics service in all region Indonesia because we have the very diversity from all the islands, and we have to harmonize of this situation. In current situation, the most of medical physicists still working routinely in the clinical to serve the patient with the collaboration with the other professional. But we still have some lacking for the research. So that I encourage to AFISMI members and also working in the clinical department and also medical physicists working in the academic department in the university to join together to have some collaboration for research, so we can find out something, methods, equipment, and also some other things for the benefit for patients. We believe that all participants will learn and improve their knowledge with attending this workshop. I hope the all participants, especially from the office members, sitting until the end of the workshop, because we offering 5 credits. So I hope that not only you get the credit from this for the administration, but I hope that you learn much from the speakers. What is the current research and innovation in medical physics and biophysics? We hope that this activity will induce international collaboration in research, education, and also training with the Indonesian stakeholders and also the international community. Again, thank you very much to Airlangga University team and also AFISMI chapter East Java who contribute to organizing this workshop. I hope all of you enjoy during this workshop. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. I'll give back to
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Supriyanto, for the speech. And then next to the agenda, the prayer will be led by Mr. Dr. Andes Arif Wibowo, MSI. Please we welcome Mr. Arif Wibowo. The virtual stage is yours. Bapak Arif, monggo Pak untuk doa.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Bismillahirrahmanirrahim. Hamdan yuwafi ni'ama uqafi umazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhika wa 'azimi sultanik. Subhanaka la nuhsi sana'an 'alaik anta kama asnaita ala nafsik. Wa sallallahu ala nabiyyina Muhammadin wa ala alihi wa sahbihi ajma'in. Alhamdulillahi rabbil alamin. In the name of Allah, who is all gracious and merciful, all praise to Allah, Lord of the world. Hopefully, salvation and safety are always given to the Prophet Muhammad sallallahu alaihi wasallam. Ya Allah, we are currently holding an activity webinar World Class University collaboration with AFISMI entitled Current Research of Biophysics and Medical Physics. Oh my God, give us our guidance, mercy and pleasure. Give us the confidence to do it. Ya Allah, so great benefit for us and for our society, university, nation, and our country. Rabbana anfa'na bima 'allamtana wa 'allimna alladhi yanfa'una wa zidna 'ilma walhamdulillahi ala kulli hal. Ya Allah, forgive us our sins if we make mistakes or faults. Rabbana dhalamna anfusana wa illam taghfir lana wa tarhamna lanakunanna minal khasirin. Rabbi zidni ilma wa wasi' li fi rizqi wa barik li fi ma razaqtani waj'alni mahbuban fi qulubi ibadik wa azizan fi ayunihim waj'alni wajihan fi dunya wal akhirah wa minal muqarrabin ya katsiran nawal ya hasanal fi'al ya qa'iman bil zawal ya mubdi'an bila misal falakal hamdu walakal minnah walakal syaraf ala kulli hal. Rabbana atina min ladunka rahmatan wa hab lana min amrina rasyada. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wa sallallahu ala nabiyyina Muhammadin. Alhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Waalaikumsalam warahmatullahi wabarakatuh. Amin, amin ya rabbal alamin. Thank you, Mr. Arif Wibowo. We hope that this event we come to the main event, which is the lecture by the panelists as well as discussion and Q&A session. This session will be guided by Madam Nurul Fitriah as moderator, MSc as moderator, and then will be followed directly by Prof. Suharningsih. Brief introduction, Ma'am Nurul Fitriah is currently working as a junior physics lecturer at Physics Department, Faculty of Science and Technology, Universitas Airlangga. She is part of medical physics and biophysics laboratory member. She does research in radiology for medical application and material science, especially bioactive coating material for medical application. Please we welcome Ma'am Nurul, the virtual stage is yours.
Thank you for the MC, Ms. Kartika. Bismillahirrahmanirrahim. In the name of God, who is the most gracious and the most merciful. Assalamualaikum warahmatullahi wabarakatuh. Peace be upon you. I would like to thank you for your attending. Dear participant, before I start the speech of Professor Cheng Shao, I would like to read his short biography. Welcome for Professor Cheng Shao and all the audience, including medical physicists, student, lecturer, and alumnus for all over the Indonesia. Welcome to our webinar series as part of World Class University program and to celebrate the 66th birthday of our university, Universitas Airlangga. As I know today, there will be a wonderful lecture after this, and I'm pleased to welcome Professor Cheng Shao, a very special guest from Northeast Radiation Oncology Center and ROC Dunmore, Pennsylvania. And Professor Cheng Shao is a senior medical physicist in the Northeast Radiation Oncology Center and ROC, Pennsylvania, USA. Professor Shaw's specialty is radiation oncology, in particular in brachytherapy. He was among the few looking at the quantitative assessment of interstitial implant using iridium-192. At the time, radiation oncology was evolving into the computerized era and image-based planning. He received his PhD degree in experimental low nuclear physics from the Florida State University, Tallahassee, USA in 1983. And he was certified by the American Board of Radiology in Therapeutic Radiological Physics in 1989 and the American Board of Medical Physics in Radiation Oncology in 1990. Professor Shaw has authored and co-authored over 80 articles, 20 book chapters, 5 news articles, and 120 the scientific peer review panel member in various sections of radiation oncology of the Department of Defense USA from 2001 till 2010, and engaged in 5 expert missions of International Atomic Energy Agency, IAEA. Professor Shaw also has been actively engaged in international transfer of complex imaging and radiotherapy technology. He has been organizing workshops and symposia with the local organizer or institution in the Asian Pacific region since 2000. And among the countries that benefit from his mission are India, Indonesia, China, Malaysia, Singapore, Sri Lanka, Taiwan, Thailand, and Vietnam. And he has made over 120 educational presentations in these countries. He also wrote the textbook, Foundation of Radiological Physics, and now working on therapeutic radiological physics textbook. Finally, ladies and gentlemen, in the next 45 minutes, you will learn about towards artificial intelligence in radiotherapy treatment planning, including radiotherapy machine, procedure, and dose delivery. Let's get some inside knowledge from somebody who has been there and done it. Would you please welcome Professor Cheng Shao, PhD FAAPM. Professor Cheng Shao, time is yours.
I hope you guys can hear me.
Yes, we can hear you, Prof.
Thank you very much for inviting me over here, and I'm trying to figure out how to do what they call it, the new normals, and trying to figure out how to use the computer to do webinar. Thank you for having me in the lectures. I think I don't have a picture of myself up here, right? I think.
Sure.
I think. I don't think I see my pictures here, right?
You can turn on your video, Prof.
Let's start video.
Yes, your video.
Yes.
Okay.
Yes,
Yes,
we
yes,
can
we
see
already.
you.
Yeah, we
Thank
can
Welcome.
see you now, Prof.
Helping out. Still not a
Yes, we can see you, Prof.
okay. I have all these funny things popping up on my computers.
Sure, take your time, Prof.
Okay. So I was longing to go to Chiang Mai last year in March and Brunei in around June. However, because of this COVID-19, we are stuck in our own homes, and so I'm in my home right now, just like the rest of the people in the United States. But anyway, it's good to learn new things. I was invited and I was thinking of what type of lectures I should give. And finally, I gave in and chose something that is happening in my institution, that is treatment planning. And we just got a new module called a trade-off. A trade-off modules that decides different type of organs at risk that we are trying to use it to see how it works. Anyway, so that's my thinking, and I hope that by going through the treatment planning systems, some of you who are looking for, who are in the medical physics programs and looking to become medical physics, they would give you some insights to the work in treatment planning, which is an essential component of radiotherapy. So by doing that, I'm going to go to my slides, which I click share screen. And I think it's over here. Does it expand or open screen, right? Open.
Yes, you can. Yeah, you can press share screen, and you will be offered to open which file.
Can you guys see this thing?
Yes, we can see.
Yes, Prof.
Okay, let me just go to the file. Okay, so let me do another things over here, which is, are you guys okay over there?
Yes, we can see.
Yes.
Okay, so I'm looking at the fact that in treatment planning, we are moving towards more automations. So let me just do some basic discussions here. The first thing I'm going to give is an outline. What is radiotherapy and what is the role of radiation therapy and what does radiotherapy entails, and if a patient visits a radiotherapy center, what the patient has to entails, and one of them was doing planning. And then I'm amazed that treatment planning now is computer-based, which is basically, if you know the formalisms, you can basically ask the computers to do whatever you want to do. So the first thing is, I assume that your institutions graduating bachelor's, master's degrees, people and training in this area. So my introduction of radiotherapy is generally radiotherapy is associated with cancer management. It is one of the tools used to treat cancer. Now, the management of cancer involves two other disciplines besides radiotherapy is chemotherapy and surgery. Now, what does radiotherapy do? We use radiotherapy to treat functional disorder, benign tumors, and also relieve symptoms. Functional disorders, one of the way of the use of radiation is, this is one of the earliest discovery of the use of radiation is the arterial malformation. Arterial venous malformation is the abnormal formation of blood vessels where the artery bypass the capillaries, tissues, and reach the vein. Essentially, the blood doesn't go into the tissue, it goes from the arteries and out into the vein. So therefore, there is a suffocation of tissues. And so one ways of supplying blood or nutrients to the tissue is to give radiation to block this bypass. The other thing is trigeminal neuralgia, which is some of the patients, they feel pain in the face. And when they feel pain in the face, that's caused by a nerve. And that nerve, in order to relieve the pain, is to kill the nerve. And this is a functional disorder that there is no cancer involved. It's just trying to manipulate the human systems. Now, cancer is also used, radiotherapy is also used to treat benign tumors. Those are slow-growing tumors that arise from the cells. I give you two examples. One is the pituitary adenoma, which is that grows from the pituitary glands, and that's basically inside the brain area, right smack in the center of the head. And the other one that is commonly used for treatment is schwannoma, which is benign tumor of the nerve of hearing, the cranium, and that's causing hearing issues. And the third use is basically pain. Radiation can use to stop pains. And one of them was if there is a tumor that compress onto the spinal cords, it can cause pains or the compress in certain nerve, it causes pains, and one of the pain relief is using radiotherapy. The other one is paralysis. Commonly, it is called cord compressions whenever there is a tumor that is pushing onto the cord. If it is not treated within 24 hours, it can cause paralysis. The third examples of relief of symptom is bleeding. Cervical cancer, usually the patient doesn't feel anything and the patient knows that there is a bleeding. One mechanism of stopping bleeding is using radiotherapy for treatment. Now, I basically was looking and asking the questions, is radiotherapy the preferred treatment modality in cancer center? True or false? Does anybody knows what's the answer? Anybody can say? I don't see any. Anyway, the answer is radiotherapy is not the only treatment. It depends on the the type of disease. For example, if it is localized, then radiotherapy can be used. But because radiation can cause secondary cancer, the preference is to do surgery. If the surgery cannot be done, then they lean towards radiotherapy. That is considered localized treatment. Chemotherapy is generally used for a systemic treatment. That means the whole body is trying to kill cells that is floating around in the circulatory systems. So each of the discipline has its own area of its own area of applications. Chemo generally, radiotherapy is generally followed by chemo or before chemo or during chemo. If it is the same time as chemo, is called adjuvant radiotherapy. Sometimes the chemo and radiotherapy works together to enhance the effects of the treatment. Now, this is the second part is, what is radiotherapy? Radiotherapy has four broadly. One is the brachy, the other electron beams, the third is particle beam, and the fourth is a generalized called external beam radiotherapy. Now in brachytherapy, what that brachytherapy is the radiotherapy treatment where radiation sources is placed inside the patients, which is like in cervical cancers or in tissue interstitial treatments. They are directly inserted into a catheter, a tube. The tube is inserted into the tissues, and finally we inserted the sources into the tubes and let it be there for a defined time period for the treatments. So the graph shows you is the iridium-192 source is generally the low energies compared to the other energies for treatment. So the treatment depth for radioactive source is shallow. The other one is, I show you the protons with is the sharp peak, and then the photons beams is typically they have a decaying type, exponential decaying type beam, and the electrons are more towards shallow treatments. So electron beams are generally used to treat superficials. That means on the surface of skins and tissues, generally they're very effective because of the short penetrations. Particle beams are currently of interest is because of the fact that it's an expansion of radiotherapy. Particle beam, two particles that is being worked on is the proton beams and the carbon beams. Proton beams are proton particles, and carbon a little bit much larger. The difference between protons and carbon is because of the energy transfer. Because they're big, they generally deposit lots of energies, and for those type of beams, they are generally used to treat what they call oxygen deprive tumors, and generally they have a higher effect compared to the protons or the photons. And these are the particle beams are increasing in use around the world. Now, external beam is the most common type of radiotherapy. The external beam uses photon beams. Basically, it's an energy beam. Photons are energy, and when we call it external, the source is at a distance from the patients. The picture shows you that the radiation source is actually in the machine's head, and then the patient is at a distance, usually right now commonly is about meter away. These are the most available type of radiotherapy around the world. It's most available around the world compared to the carbon or photon beams. Now, the delivery of radiotherapy, there are different types of machines being used for delivering radiotherapy. The common one is called the medical linear accelerators. That is they call it a C-arm type that looks like a C-arm attached to a stand. So these are the traditional old machines that has been for years. And the next one is called the tomotherapy, where the source spins around the patients as the patient move into the boreholes. So the tomotherapy is like a CT scan, except that the radiation beams, the beams are not imaging beams, but treatment beams, which is higher in photon energies. The next two, the one on the left is called a cyberknife. What it is the radiation comes from the attachment on the top of the robotic arms. The robotic arms looks like a mechanisms where they are being used in car industries, where the robotic points and seals different area of a car. This principle works on the use of robotic arms that move around the patients. So what happened is when it moves to a certain spots and then it stops, then it gives radiation, then it moves to a different spot around the patients and then it gives radiation. Typically, the software that runs the cyberknife has like over 150, they call it nodes. Nodes are positions where the machine stops and then gives radiations. The next one is called the gamma knife, which is on the right side. The gamma knife is intended to treat the head of a patient. So when it works is the patient move into the gamma knife holes and then lock there, stays there, and then the radiation is given. And then if you want to treat the different spots, then the patient has to move. There is a mechanism of moving the treatment couch or the table or the couch that the patient lays, so that the center of the radiation points to is the tumor is moved to the center of the point the radiation is given out to. Now, those are the machines, the radiotherapies, and now we are looking at the procedures. In the modern time, radiotherapy procedures are very standardized. They go through the same sequence. The first sequence is they, when the patient comes in, they'll be they'll be asked to do a CT simulations where the purpose of the CT simulation was to set the patient in the comfortable position. Generally, they are aided by, they call immobilization device, anything that can stabilize the patients. After they decided that the devices or the things being used to stabilize the patients, that the patient's comfortable, then they put the patient on the CT scans and then they scan the patient. The purpose of scanning the patient is to get the patient anatomy, the tumor, the critical organs and the locations, and then they send them to computer stations that do the treatment planning. The purpose of treatment planning was to decide how to deliver radiation treatment to the patients. And then finally, once that thing is complete, whatever that is being done on the treatment planning parameters that is being accepted will be sent to a radiotherapy machine, generally refers to radiation dose delivery system. And from there, the machine would pick up the information and then deliver the radiation dose. Whenever the patient comes to the treatment machines, they are being aligned to what the treatment planning computer says. So the alignment process is done using imaging facilities. What they call is image-guided radiation therapy. They localize the patient, they move the patient to the right place so that the beam points to the right area. So in treatment planning is basically downloading CT image set, define patient setup, design treatments, and then exports them to the dose delivery system. The dose delivery system will pick up the treatment planning parameters, set up the patient, localize the patients, and then deliver a radiation dose. Now, what I have said is, if you really think about it, we are in the positions where most of the equipment that we use are highly technical equipment, without a CT, without treatment computer, high-speed computers, without the machines, we actually cannot do radiotherapy. So radiotherapy is a very technological driven medical subspecialty. So we need all this equipment to perform even simple radiotherapy. So now, the focus I'm trying to bring to you is on treatment planning. What does we say treatment planning? What do we do? And the basic idea of treatment planning was, after the patient has been scanned, the CT scan is used to construct the patients. And in constructing the patients, there's patient data, which is basically the location of the tumors, the positions of the critical organ structure, and then if it is in the head, where the eyes are located, where the nose, where all these they call optic nerve and all those radiation sensitive being contoured. And essentially the difference between modern radiotherapy and ancient therapy, the older called traditional, is that there is no patient. You scan the patient, you ask the patients to go home. And then you reconstruct on the treatment planning systems, and then you can plan to provide a good plan and do the planning as long as you can, the best you can until you're satisfied. So those planning or treatment planning is basically a software, is a virtual simulations of the patient to be treated. Now, what is the philosophical approach to dose planning is the coverage of the target volume of tumor. If you cannot deliver the radiation dose to the tumor, there's no point treating. And the other thing is you have to deliver the dose uniformly across the tumor or the target volume. Generally, the target volume means the tumors plus and some margins. Margins are the additional volume that needs to be treated to ensure that the tumor is being treated. And of course, the idea of sparing the surrounding tissues is because radiation cannot be delivered directly to the tumor. They have to be from the outsides, and then they pass through some tissues, and then they come to the tumors, and then they go through the patients. It's basically the radiation is like flashlights. It goes through the patient's body. So there is consequence to the fact that the delivering of radiation is not precise, but using the beams as they degrade, as they penetrate through the patient, they degrade down. Here is an example of a single beam. A single beam going through the pelvic area. That is from the right side. If you see the red area, that is the hottest part, and then it goes, and when it turns blue, it gets cooler. So radiation effect is if you give a radiation from one side, it started hot, and then it goes cooler and cooler as it goes through the patients. You can see that if the tumor is basically at the center, then the single beam would give a lot of radiation to the normal tissue. So this type of treatments is not viable because the tumor get less radiation than the normal tissue. So to improve that, one mechanism is to give radiation from both sides. If you get both sides, then the center would get a little bit more radiation. However, the tissue besides both sides are getting more compared to the target volume. And then you can see that now the hotspots move to both sides. But if you decided to give 4 beams, if they cross over back and forth, then you see that the most radiation is delivered to the center of the target volume where you want to treat. Now, as a consequence of putting multiple beams in, putting additional beams in, what you have done is you have given radiations to the normal tissue. If it is from the left and right, the femur is getting radiations from the up and down, the rectum area and the bladder area, you're getting more radiation. So the questions in treatment planning is to decide how much radiation can the bladder get, and how much radiation the rectum can get, how much radiations the femur can get, and what's the overall effect of all these things. So the effect of radiation toxicity is a function of the dose. So what the modern treatment planning system is capable of doing is to get the dose, the volume that receive a certain dose as a function, the volume that receive a certain dose as a function of dose. And that is what you see on the upper right. The upper right gives you the dose, which is, if you see on the upper scale is the dose, the lower scale is the relative dose. The relative dose is the dose that is relative to the tumor. The red line is the target volume they receive, and then the other beige lines, blue lines, they are all organs at risk. So the question comes is, how do you know what dose is considered unacceptable, and at what level is considered unacceptable? Or is that a way of figuring out what constitutes acceptable, unacceptable? Just to point out that the use of multiple beams in treatment planning is essential, and then the cross-firing means you put as much beams to the center of the target volume, As you see in the example, we use forces the concentration of high dose to the target volume. So you can increase the beam to 5 or 6 or 7 or 8, depending on the target, the normal tissue you want to spare. And the general word is called organs at risk now. So this is called the dose volume histogram. It gives you a function of the volume that receive a certain dose, at least a certain dose. So if you see, for example, if I choose a baseline that receive, like, this is inverted here, the dose, say 500, 20% of this organ at risk will receive 500 centigrade. So it's what they call a cumulative dose volume histograms. So you see that thing goes up to 100 and then stretch through, is because all the volumes, all the organ receive at least that minimum dose. In dose planning nomenclature, the planning target volume is actually they call it the clinical target volume, or the target volume that is determined by the doctors to be considered needs to be treatment. The planning target volume is the additional margin, the additional tissue that needs to be included, so that the clinical target volume, the volume the doctors wants, is actually covered, given uniformly as the doctor wants the dose to be. And then the other line is called organ at risk, normal tissues or organs that needs to be delineated, or needs to be contoured, or need to be outlined, so that we are able to derive the dose volume histogram. So in order for a treatment planning to be acceptable, they must cover the target volume and spare the normal tissue. Again, what the sparing normal tissue means that the organs at risk, those organs that are considered, has to be judged by the radiation oncologist to say that, well, if you give more than a certain amount, they're going to cause difficulty to the patients. For example, for kidney, you can have kidney failure. For bladder, you can cause complications such as fistulas or rectum. For example, if you give a certain amount, you can cause inconvenience. If there is fistula, then you have diversions, and then you have all sorts of things that. So there is a risk associated with radiotherapy treatments. And the best way is to keep the radiation dose as low as you can, but if not, you want to keep them low enough that they would not cause radiation toxicities. Over the recent years, there is publication on what constitutes the amount of dose that can cause radiation toxicity. One example, this is what they call the contact values. This is published 10 years ago in International Journal of Radiation Oncology, Biophysics. And they list based on calculations and their experience, they find out there's certain values that you should not exceed. And here is, they create a table, for example, brain, organs, 3D, how much dose it is. So they give you some criteria. And so this criteria is being being refined as a function of times. And so my point is, those constraint is available and they are being refined, making it better, more precise. There are two ways of doing treatment planning. One is, I illustrate to you, is what they call a forward planning. Forward planning means you place the radiation beam yourself, you decide whether the dose pattern is good, whether they cover, whether the dose to the organs are low, and those are called forward planning. There is also a process called the inverse planning. In inverse planning, we use the dose constraint, which is basically the dose objective, and then you set these things up, and then you ask the software to give radiation beams. You either decide the beam, the beam where you want it, then you ask the computer to give you the best options, which is basically some mechanism of minimizations of the difference between what you plan and what you should get. And this process led to the introduction of intensity modulation. The intensity modulations allows some of the beam to be modulated so that the whole beam may not give you a uniform beam fluence, but the plan will give you a uniform dose across the target volume. Here is an example of, this is what they call the RPC thorax phantom. The intent of the pattern is to irradiate a target volume, and then they put in a cylinder anatomy geometry, like a cord, like the heart, lung, and then they ask you to do a plan. So this is a plan that I recently did to do a certification of my linear accelerators, consistent with treatment to be given as a means of checking whether the treatment machine performs as what is supposed to be told by the treatment planning system. Again, the sequence is you do the plan and then they give you a DVH. So how does the inverse planning works? The inverse planning works is you need to contour basically the planning target volume, different features like the heart, the cords, the lung, and then you have a bunch of this called organ, the planning target volume and the objective. And so once you plan, you set up what is the values they are supposed to be. For example, you want the planning target volume to cover the you want the beams to cover the planning target volume, then you have to set the minimum dose that you would allow the planning target volume to have, and then the maximum dose the target volume should have. Likewise, you can ask the questions, give the questions on what is the maximum organ at risk dose you want the plants to have. And then once you do that, you go through the process of setting it up, and that's being defined by the arrowhead on the DVH, and that allows you to do the planning. And once you do that, this graph shows you that the computer do the calculations, and then they tell you what the numbers are. And earlier I mentioned intensity modulations, and the newer technique is called volumetric modulated arc therapy. The difference between intensity modulation is the person who do the planning, the dose planner, decides where the beams are supposed to be, where it's being placed around the patients. And then the target and organ at risk constraints are then optimized to optimize the treatment plan. If that is not successful, then you can change the organ at risk, and then you redo them again. So this process is very iterative, but you change a certain DVH criteria objective, and then you do the optimization again. For VMAT is basically, instead of beam placement, we use what they call an arc length. Arc length is in a rotational fields, they tells you what's the total arc you want to give. In a traditional treatment planning machine, usually we have reached a point that most of the time the arc is 360, a complete rotations. In certain cases, for example, treatments of one-sided lung, 180 arc length would be used instead of 360. That is intended, attempting to avoid radiation dose, any radiation dose to the contralateral, the lung at the other side. And the same mechanism is being used. The target and organ at risk constraint are used to optimize the treatment plan. And this process is still the same way. It's an iterative process. That means you do a little bit changes and see what happened. You do a little bit and then you see what happened. Now, whenever you have completed the plan, the doctors would use the DVH to decide, and that's compared to their clinical protocol, whether they're satisfied or not, whether they need to be changed or not. And sometimes the doctors may prefer one organ versus another organs. They think for some reasons one organ may be more important than another organs. And as a dose planner, you don't know which organ is more important than the other organ. So you have to rely on the doctors to tell you, the radiation oncologist, the doctors to tell you which is which. And then you optimize again. And you can see that most of the time is based on the interaction between the doctors and dose planner. The question this picture presents is the next levels of complexity. These patients have like 9 metastatic lesions, and technically, if you need to treat, then you generally would requires a complicated procedures. But with a modern system, you can easily set up the treatments. Here's an example of the lesions, and the color wash give you the type of radiation dose delivered. And this patient is being treated on the linear accelerators in 15 minutes, less than 15 minutes. So the point is complex things now made simple by computer softwares that we use for virtual planning. And here's an example that shows you head and neck treatments. And head and neck treatments is complex is because there's so many organs. And you can see on the upper right, all the lines that needs to be considered when you do those planning. And I say you take as long as you like is because you need to satisfy all these criteria of those volume histograms. And this case 3 is to look at the idea that modern radiotherapy is based on evaluating coverage and sparings of organs at risk. Most of the other things are not generally fairly simple. So this is the last portions, a few more slides here. This is called the MCO, multi-criteria optimizations. We just got this thing turned on our computers within a month. And the vendor is the Eclipse variant vendor that created tools that explore the trade-off between coverage normal tissues for IMRT and VMAT. And this is a simple diagrams that doesn't show you much different except that you do the planning the same way. You have those constraints that you put on the left side, and then you see the deviation, and then the arrowhead points you to where you need to go. You need to use the system to push it. And once you decide that, then you go to via menus, and then you see the explore trade-off. And in the trade-off, you select what you want to do the trade-off. So this is still a decisions you have to make. And then what happened is the computers would calculate a bunch of options for you. And then on the left side, they give you a bar that slides back and forth for this limited number of organs that you choose. And these organs tells you which one you want to reduce down the dose as you and the doctor decide. At the end of the day, it comes back is, of course, this is a checking list. And at the end of the day is when you slide this bar, on the lower left, there is a clinical objective on the lower left that if you slide the bar correctly, this would turn green. If it is outside the constraint, it will be red, and then you slide it and turn until it turns green. And it's interesting to me is all this thing is done by computer, and this is one options that the Eclipse treatment planning do. But if you think in a wider scope, all these things can be done using computer software. And basically you don't need, if all you want to see is green, you can use these things. You don't need the mechanical, you can do this automatically.
I'm sorry, Professor, your time. You have around 6 or 7 minutes for the question.
Okay.
And
one.
Yes, actually there are 3 questions that the participant asks for you. The first one is from Reza. He asks about, as long as I know, electron is a particle or beta negative, but in the type of radiotherapy looks like electron beam therapy, and the particle beam therapy is something different. What is the difference between both of them? And so that the electron is distinguished from the particle beam therapy, whereas the electron is a particle. It's kind of like she asking about the characteristic or the definition or the differences between those particles, Prof.
Okay. Now, the electrons is actually a particle. Electron is a particle, but we don't consider them particles because of the weight. It is too light. And so they distinguish the particles starting from protons onward. Is that clear? Hello?
Yes, Professor. And maybe one more question
Yes.
From Dina. I would like to ask about radiation or radiotherapy, as all the world is busy in discovering the cure for the COVID-19. So why not the radiation will be used for that? COVID-19 has been reported to affect the human's lung and liver specific tissues. So what if this part of the part that been exposed for the COVID-19 can be cured by the radiation or something like rapid recovery for the patient? Is that possible or not, Prof? Thanks.
That's a good question. There's a good question is there's two sides to the story. One side is whenever you give radiation, there is in your mind you should be thinking of secondary malignancy. First thing. The second thing is whenever you give radiation to a patient, how does it works? And radiobiologically, the radiation doesn't kill the virus, but you can use radiation to provide some sort of a resistance, but the idea is how much to give. And we don't know. To kill virus, you need kilograms. That means you do way higher than you need for a person. You can kill the patient and then you kill the virus because the dose is too high. So then you ask the question, what is the dose that is required for the patient to feel comfortable enough that the patient feels okay? One mechanism of using radiation is inflammation. If you give radiation so the patients feel comfortable without the inflammations, then you have succeeded. But you also have other drugs that you can do inflammation, like steroids. So when you use radiation, you're actually introducing risk to the patient.
Okay.
Does that answer the questions?
Yes, Prof. I think the participant that asked this question can learn more and read more some reference related to this question. Actually, the time is up, but there's one question I think from the medical practitioner. So I think you can give a short answer for this. And for the participant that you cannot get the answer because so many questions, you can send the question later. I will ask later for the Professor Cheng Shao. This is the question, Prof. In those planning strategies, since the process is iterative, can you please describe shortly how the optimization process works? How good is like the optimization stage?
The optimization process is created by, I say mankind, is because different people think it differently, what optimization is. And so when you have different treatment planning system, they do it differently. So the question comes, optimization is methods of minimizations. Of course, you can say different, such as they use rolling hills to point out how they do up. Is basically comes is the difference between what you calculate and different compared to what you decide. So if the difference is large, then they try to figure out how to make it smaller. So there's they call it simulated annealing process. There is one. The other one is, I think, is the simulated annealing is early versions, and there's the process. But actually, is the difference between the two. except that when you have too many parameters to calculate the difference, then it becomes complicated. And one way to get around that was to ask the questions, what is the general tendency of the doctors to have priority? Then you have to go through the collections of different organ at risk, and then you have a pattern. Once you have a pattern, then it becomes more like artificial intelligence. Then you come to a process that what is generally called accepted idea, then you can deviate from there. Then you don't have the calculation. Right now, the multi-criteria process is complicated. Complicated means it's still very naive in a sense. You only can do a few, and then it takes a long time. What the computer does is it changes one of the parameters, then it calculates again, it changes another one, it calculates again, it changes another one. Then you have a list of plans for you, and then you slide this to find which one you want.
Thank you so much, Prof. Actually, I'm so welcoming to the second speaker, but let me say something as acknowledgement to Professor Chang Shao. Thank you so much for the amazing talk and fruitful discussion. We hope we can collaborate again in some program that Universitas Airlangga will overview in the near future. Such program like the Kota program, especially for courses. The second one is our academic peer list program, which this program is actually to enhance our institutional performance by collaborating with you in the next webinar and research collaboration, etc. So based on your expertise as medical physicists, we wish you are willing to be one of our academic peer list. And the third one is a young professor. Finally, we have come to the end, to an end section for our first speaker. Professor Chang Shao, you are allowed if you want to leave this webinar, and if you still want to stay with us, thank you so much.
Yeah, thank you for having me.
Thank you so much, Prof. Thank you so much. Yeah, thank you so much. And please give a big applause for Professor Chang Shao.
Okay. Hope you guys have a good time going through the web seminar. Thank you.
Thank you so much, Prof. Okay. Now we continue to our second speakers. Dear Professor Tiang Hondai, welcome to our webinar series as part of world-class university program and to celebrate the 66th birthday of our university, Universitas Airlangga. Please let me read for the Professor Tian Hongdai short biography. Today, for the second speaker, we are pleased to welcome Professor Tian Hongdai, PhD, as our next special guest from Harvard Medical School and Wellman Center for Photomedicine, Massachusetts General Hospital, Boston, USA. He received both his master and doctoral degree from China Agriculture University in China around 1992 and in 1995, respectively. His latest postdoctoral training in 2006, 2009 under supervising Professor Michael R. Hamblin at Dermatology Department, Massachusetts General Hospital and Harvard Medical School. And in 2012 until now, he is currently work in Dermatology Department of Harvard Medical School and as a young professor in School of Medicine, Tongji University in China. His editorial activities recorded more than 61 reputable journals, which employed him as ad hoc reviewer, and more than 10 periodical turns as editorial rules among high top quality journals. Professor Tian Hong's research focuses on using light-based antimicrobial therapeutics for an antibiotic-resistant infection. In particular, his team has been interested for some time in the use of antimicrobial blue light, ABL, to treat localized infection. Currently, he commits 80% of his time to research and original creative work, 5% to professional service, and 50% to mentoring and teaching. He did some collaboration with other investigators from both inside and outside Wellman Center. He is also working on several other projects, including the use of optical microneedle array and optical clearing technique for improved therapeutic like delivery into human tissue, and photo vaccination for the control of sepsis, and also the design and synthesize fluorenyl nanophotosensitizer for oxygen-independent antimicrobial photodynamic therapy. And if we look forward about his past research, he already got in over 100 publications in peer-reviewed journals with H factor 48 and more than 7,900 citations from Google Scholar data. Wow, it's so amazing. And over 20 invited plenary and keynote presentation at national and international conferences. And he also is the founding chair of the conference, Photonic Diagnosis, Monitoring, Prevention and Treatment of Infection and Inflammatory Disease at the SPIE, International Society for Optic and Photonic Waste. Wow, such an awesome biography. On this occasion, he will be sharing with us his expert knowledge on photodynamic therapy for medical application. Ladies and gentlemen, please join me in welcoming Professor Tian Hong Dai, PhD. Professor, the virtual stage is yours.
So can I share my screen right now?
Sure, Prof.
Okay. So, okay, hello everyone. So first of all, I would like to take this opportunity to thank the organizers of this symposium for giving this opportunity to discuss with you about my research today. So my name is Tian Hong Dai from Wellman Center for Medicine, Mass General Hospital, Harvard Medical School. So the story I'll be talking about today is antimicrobial blue light inactivation of pathogenic microbes. So, although the microbiologists have been ringing the alarm bell for years, the threat of antibiotic resistance has reached a new prominence in the popular press that this issue should be added to the list of global emergencies. It is now indisputable that antibiotic-resistant infections are life-threatening in the same sense as cancer, both in the number of cases and the likely outcome. So, according to a recent report released by the USA CDC, each year in the United States, over 2 million people are infected with antibiotic-resistant pathogens, and over 23,000 patients die as a direct result of antibiotic-resistant infections. So antibiotic resistance results in as high as $20 billion additional cost to the US healthcare system. So in addition, there is about $35 billion loss to the society because of the loss of the productivity of the patient. So in 2015, the White House announced a national action plan for combating antibiotic-resistant bacteria. And in October 2020, they released a new version of this action plan. So it is noted in this national action plan that our drug choices have become increasingly limited and more expensive, and in some cases non-existent. Modern medical advances such as surgery, transplant, and chemotherapy may no longer be viable due to the threat of infection. So one of the specific objectives as outlined in this national action plan include the development of non-traditional therapeutics and combination therapies for bacteria infections. Okay, something. Oh, sorry about. Okay. So also recently, Dr. Karen Bush from the Indiana University together with other 29 experts in antibiotic resistance, they appeared in the Natural Reviews of Microbiology that the investigation of novel non-antibiotic approaches for the prevention of and protection against infectious disease should be encouraged, and such approaches must be high priority and research. And sorry, something is wrong with my computer. Okay. High priority research and development projects. So as a type of lung antibiotic approach, light-based antimicrobials such as antimicrobial photodynamic therapy and ultraviolet C radiation have been extensively investigated as an alternative for the treatment of infectious disease, particularly localized infections. So the mechanism of antimicrobial photodynamic therapy is a combination of light and a compound called photosensitizer. In the presence of oxygen, light activates photosensitizer, leading to the production of cytotoxic reactive oxygen species that can kill the microbial pathogens. And the mechanism of UVC inactivation of microbial pathogens is the absorption of UVC radiation by the DNA of the microbial cells and the subsequent prohibition of the microbial cell replication. So in 2018, a new conference was founded at SBI Photonics West, particularly dedicated to the area of photonic diagnosis and treatment of infections and inflammatory disease. So the advantage of light-based antimicrobial approaches, the first is the rapid action. The light kills the microbial cells within minutes to hours, while it usually takes antibiotics days of time to take effect. And another advantage of light is equal killing effectiveness regardless of the antibiotic resistant profiles of the microbial pathogens. However, the practice of using light-based antimicrobials also revealed some limitations. For example, of antimicrobial photodynamic therapy. The first limitation is the challenging of introducing exogenous photosensitizer into certain microbial cells, and also the less than perfect selectivity of many photosensitizers for microbial cells over the host cells. So as a matter of fact, so there is still no highly effective antimicrobial photosensitizer that has been approved by the FDA. And the use of UVC irradiation, on the other hand, has its limitation due to its detrimental effect on the host cells and the possible damage to the host tissue. So a novel light-based antimicrobial approach, antimicrobial blue light, has attracted increasing attention due to its intrinsic antimicrobial activity without the involvement of external drugs or photosensitizers. The mechanism of action of antimicrobial blue light is still not fully understood. A common hypothesis is that blue light emphasizes naturally occurring endogenous photosensitizer, primarily porphyrins, and subsequently leads to the production of cytotoxic reactive oxygen species that then kill the microbial cells themselves. So in comparison to the traditional antimicrobial photodynamic therapy, antimicrobial blue light kills microbial pathogens without the involvement of exogenous photosensitizer. So it's simple and inexpensive. And in comparison to UVC radiation, there is much less concern about the blue light-induced mutagenesis effect on the host cells, so it's safe. So the whole hypothesis of our research project is antimicrobial blue light is a viable strategy for the inactivation of pathogenic microbes. So to test this hypothesis, first we carried out in vitro studies. In our preliminary study, the light source we used was a LED array with a peak emission at 415 nanometer wavelengths. And the 3 representative pathogens, Pseudomonas, Acinetobacter, and Candida, were investigated. And this slide compares the susceptibility to blue light inactivation between planktonic microbial cells and human keratinocytes. And from the results, we can see that blue light selectively inactivate the microbial cells over human keratinocytes. For example, of Candida. So when an exposure of 70 joule per square centimeter blue light had been delivered, over 5 logs reduction in Candida viability was achieved. 5 logs means 99.999%, 5 lines, while under the equivalent dose of light, only minimum viability loss was observed in human keratinocytes. As transmission electron microscopic image revealed blue light-induced damages in Candida cells. The panel A shows the intact Candida cells with typical morphology containing nuclei, vacuole, mitochondria surrounded by cytoplasmic membrane and the cell wall. So when 35.1 joules per centimeter blue light had been delivered, significant disruption of inner organelles with deformed cell wall was observed in some treated cells. And in some cases, unusual vacuole morphology occurred, driving the electron-dense materials to cell periphery. So when exposure of 70.2 joules per centimeter blue light had been delivered, complete decomposition of inner organelles with disrupted cell wall was observed in some treated cells. And a similar results was observed in blue light inactivation of Pseudomonas. The panel A, untreated Pseudomonas cells, panels B, C, D, blue light treated Pseudomonas cells, showing varying degrees of blue light induced cellular damages. And this slide shows the results with Acinetobacter and the panel A, untreated Pseudomonas cells, panels B through D, blue light treated Acinetobacter cells. So to use antimicrobial blue light in clinics for the treatment of infectious disease, one question that has to be answered is, can the microbial cells develop resistance to antimicrobial blue light activation? We don't want to see a scenario that, like, while we are mitigating the problem of antibiotic resistance, and at the same time, we are raising another new problem of light resistance. So to answer this question, we carried out repeated cycles of partial blue light activation of microbial cells. Partial blue light activation means we left a portion of some microbial cells still alive after the light exposure. And this slide shows the results with Pseudomonas. So in the first cycle of light inactivation, the blue light exposure was adjusted to produce about 4.5 logs reduction in Pseudomonas viability. And the same light exposure was then used throughout a successive cycle of blue light inactivation. The Pseudomonas cells surviving from the first cycle of inactivation were recultured and then subjected to the second cycle of inactivation. And the Pseudomonas cells surviving from the second cycle of inactivation were also recultured and then subjected to the third cycle of inactivation. And this procedure was repeated until the 25th cycle was reached. A correlation analysis indicated that there was no statistically significant between the number of cycles of blue light activation and the viability reduction in the different cycles. This tells that the development of blue light resistance by Pseudomonas cells did not occur. And a similar results were observed with Acinetobacter after 20 cycles of repeated partial blue light activation. We do not see the development of light resistance by Acinetobacter cells. Also, as we mentioned earlier, the hypothesis regarding the mechanism action of antimicrobial blue light inactivation is the photoexcitation of endogenous porphyrins inside the microbial cells. So to test this hypothesis, we carried out UPLC analysis to identify the endogenous photosensitizers in the microbial cells. And these UPLC profiles, these peaks in the HPLC profiles indicate the presence of endogenous porphyrins inside the Pseudomonas, Acinetobacter, and Candida cells. And this slide shows a quantitative UPLC results regarding the concentrations of endogenous porphyrins in different microbial cells, including Pseudomonas, Acinetobacter candida, Staphylococcus aureus, Neisseria gonorrhea, and Endococcus. And we found that for all the blue light sensitive isolates, the dominant species of endogenous porphyrin is copper porphyrin. And in some isolates, decent amount of protoporphyrin line were also detected. So Endococcus is a typical blue light resistant species, and our UPLC analysis showed that only minimal amount of uroporphyrin is presented in the Endococcus. So this justifies the selectivity of blue light inactivation of microbial cells over the human cells. Also, sorry, I missed. I think I missed this slide. So at the same time, we also used UPLC to measure the concentration of endogenous porphyrins, the host cells, like for example, epithelial cells. So what we found is that the concentrations in the human cells were hundreds times fold lower than those in the blue light sensitive microbial cells. So this just shows both the quantitative and qualitative UPLC results justify the selectivity of blue light activation of microbial cells over the host cells. So all the discussions above are about planktonic microbial cells. In the second phase of our in vitro study, we investigated blue light activation of biofilms. What is a biofilm? A biofilm is a group of microbial cells in which these cells stick to each other and often to a surface. These adherent microbial cells are often embedded in a matrix of extracellular polymeric substances. So why should we study biofilms? Because biofilms are informed in more than 8% of infections in humans, and the microbial cells in biofilms are usually hundreds to thousands times more tolerant of antibiotics than the host defense. So in our preliminary study, biofilms were formed in 96 well plates. A 96 well plate biofilm model is a commonly used model for the screening purpose of antimicrobial agents. And this slide shows efficacy of blue light activation of Pseudomonas biofilms in vitro. And the biofilms were formed in 96 well plates for either 1 day or 3 days. And from the results, we can see that in this biofilm model, the susceptibility to blue light activation of 1 day old and the 3 day old biofilms were very close. So when exposure of 440 jobs per cent blue light had been delivered, approximately 3 logs reduction in Pseudomonas viability was achieved. And this slide shows the scanning electron microscope images of Pseudomonas biofilms. The left panel shows untreated Pseudomonas biofilms, and the right panel blue light treated Pseudomonas biofilm. So we can clearly see blue light induced cellular damage in the Pseudomonas biofilms. The similar results were observed in blue light activation of Acinetobacter biofilms in vitro. So after 140 jobs per cent blue light was delivered, over 3 logs reduction in Pseudomonas viability was observed in the biofilms. So, this slide shows the efficacy of blue light activation of a dual species biofilm formed by Pseudomonas and Candida. In this scanning electron microscopy image, the large cells are the Candida cells. The small cells colonized on the surface of the larger cells are the Pseudomonas cells. So when exposure of 216 jobs per centimeter blue light had been delivered, 5 0.67, a 2.46 logs reduction in microbial cells were observed in Pseudomonas and Candida respectively. So when the light exposure was increased to 500 joules per centimeter, the viability reduction were increased to 6.34 and 3.11 in Pseudomonas and Candida respectively. So with positive results from the above in vitro studies, we then move forward to in vivo studies by using a mouse model of thermal burn injuries. The mouse burns were created by pressing two preheated brass blocks to an elevated skin folder on the back surface of each mouse for 9 to 10 seconds, resulting in 4 thickness, 30-degree thermal injuries. Like about 5 minutes after burning, microbial cells and suspensions were topically applied to the burn area. To having able to have access to the power given by bioluminescent strength of microbial cells to develop mouse models of infections as bioluminescence intensity is linear proportional to the corresponding viability of microbial cells. So the extent of infection could be monitored in real time in living animals. So this approach is a significant improvement over the traditional use of animal survival and body fluid sampling. Because microbial cells are usually not bioluminescent, so the microbiologists, they isolate luminescent gene like lux opera from the pure luminescence, which is marine bacterium, and transfer them to the pathogenic microbial cells. So under low light imaging camera, so we can see the bioluminescence emitted from the pathogenic microbial cells. So by correlating the bioluminescent intensity with the corresponding viability colony-forming units of the microbial cells, what we can see here is a pretty good linear relationship between the bioluminescent intensity and the viability of the microbial cells. And this slide shows the successive bioluminescent images of a representative mouse infected with Candida and treated with blue light, as well as representative mouse infected with the same amount of Pseudomonas cells, but without blue light treatment. In the blue light treated mouse, blue light was initiated 30 minutes after bacterial inoculation, just mimicking the scenario of prophylaxis. So when exposure of 55.8 joules per centimeter blue light had been delivered, the bacterial luminescence was completely eradicated and no bacterial regrowth was observed during the following days. While in the untreated control mouse, the infection steadily developed with time, and this mouse died on day 3 after the infection, and the bioluminescent Pseudomonas cells were detected in the blood and the liver culture of this mouse, indicating that this mouse died of sepsis. And the survival analysis demonstrated that all the mice in the blue light treated group survived, while in the untreated control group of mice, only 2 out of 11 survived. And this slide shows efficacy blue light treatment of Acinetobacter infections in mouse burn. And in this study, blue light was initiated 24 hours after the bacterial inoculation. At 24 hours after bacterial inoculation, biofilms were observed in the infected area, as seen from these bioluminescent images. When exposure of 360 joules per centimeter blue light had delivered, bacterial luminescence was almost eradicated. And this slide shows quantitative killing kinetics in the treatment of Acinetobacter burn infection in mice. Blue light was initiated either at 24 hours or 48 hours after the infection. And from the results, we can see that 48 hours old infections were more tolerant of blue light treatment than 24 hours old infections. This might be because at 48 hours after infection, the infection like became more established and penetrated deeper into skin tissue where light was more attenuated. And the similar results was observed in blue light treatment of Candida infections in mouse bones. Panel A shows a representative mouse infected with Candida and treated with blue light. And panel B, a representative mouse infected same amount of Candida cells, but without blue light treatment. Panel C, quantitative killing kinetics of a group of mice infected with Candida and treated with blue light, as well as a group of mice infected with same amount of Candida cells, but without blue light treatment. As a safety study, we also investigate the genotoxicity of antimicrobial blue light to the mouse skin cells in vivo by using a tunnel assay. In the genotoxicity study, the blue light exposure we used was 540 joules per centimeter, which was the highest dose we used for the treatment of infections in vivo. So from this confocal imaging, we can see that no tunnel positive cells were detected in the mouse skin, at up to 24 hours after light exposure. And this fluorescent signal indicates DNA damages in mouse skin cells, Here I would like to give a brief summary about the discussion above. And so in the first section of our discussion, we talked about the in vitro studies using pentonical microbial cells, including the susceptibility of the microbial cells to blue light activation and the potential development of blue light resistance by the microbial cells, the presence of endogenous photosensitizers in the microbial cells, and also the cytotoxicity of blue light to the human skin cells. And then in the second section of our discussion, we discuss about the blue light activation of biofilms, including both monomicrobiofilm and the polymicrobiofilm. And in the last section of our discussion, we talked about in vivo studies using mouse models, including blue light treatment of burn infections in mice, and also the genotoxicity of blue light to mouse skin cells. So next, I would like to take a few more minutes to share with you some information about our ongoing studies. So one of the ongoing studies in our lab is the use of dual wavelengths 460 plus 405 for the inactivation of Staphylococcus aureus. So we found in our previous study, Staphylococcus was much more tolerant of blue light inactivation at 405. Then most of the gram-negative pathogens, including the species we discussed above, like Pseudomonas and Acinetobacter. So one potential reason for the higher tolerance of Staphylococcus is the presence of staphyloxanthin, which is a golden pigment inside the Staphylococcus cells. Staphyloxanthin behaves as an antioxidant and promotes the tolerance of Staphylococcus to the oxidative stress. Also, a recent study by our collaborators at Boston University reported that staphyloxanthin could be bleached by the 460 nanometer wavelength blue light. So we had an idea by using the combination of 460 and 405 for the inactivation of Staphylococcus aureus. The rule of 460 is to bleach the staphyloxanthin and subsequently attenuate its capability as an antioxidant. And the rule of 405, as we discussed a lot above, is to excite the endogenous porphyrins and subsequently produce cytotoxic reactive oxygen species. And this slide shows a set of preliminary data. So from the data, we can see that when the Staphylococcus cells were exposed to 460 nanometer wavelengths alone, no viability change was observed during the course of the experiment. When the Staphylococcus cells were exposed to 405 nanometer wavelengths alone at an exposure of 108 joules per centimeter, less than half log's reduction in cell viability was observed. However, when we combined 460 and 405 at the equivalent doses, over 3 logs reduction in cell viability was achieved, indicating a more than 2 logs potentiation by the combination of 460 and 405. So another interesting ongoing study is the combination of blue light and bactericidal antibiotics. Bactericidal antibiotics. The rationale is the following. So, bacteria growing aerobically, they produce low level of endogenous ROS as a metabolic byproduct. And the studies also found that increased level of endogenous ROS generally increase the susceptibility of the bacterial cells to the external oxidative attack. For example, the attack by the exogenous ROS. It was also reported that bactericidal antibiotics kill bacteria in part by producing exogenous reactive oxygen species ROS. And as we discussed above, so blue light at 405 nanometer could produce actual endogenous ROS by the photoexcitation of endogenous porphyrins. So we had a hypothesis that by using blue light to produce increase the base to produce actual level of endogenous ROS and subsequently increase the basal level of endogenous ROS of the bacterial cells, we can potentiate the bactericidal activity of the antibiotics. And this slide shows the potentiation of the activity of levofloxacin against the highly resistant isolate of methicillin-resistant staphylococcus by blue light. From the results, we can see that when the staphylococcus cells were exposed to the levofloxacin alone at all the concentrations tested from 1 MIC to 1S MIC, no viability change was observed during course of the experiment. So when the staphylococcus cells were exposed to blue light alone at the exposure of 216 joules per centimeter, approximately 2 logs reduction in cell viability was observed. When we combined levofloxacin with the blue light, even at the lowest concentration, like 1/8 of MIC, over 5 logs reduction in staphylococcus viability was achieved, indicating a more than 3 logs potentiation by the combination therapy. This slide shows the potentiation of streptomycin against the highly resistant Acinetobacter by blue light. Similarly, when the Acinetobacter cells were exposed to the streptomycin alone, no viability change was observed during the whole course of the experiment. When the Acinetobacter cells were exposed to blue light alone at exposure of 108 joules per centimeter, approximately 2.5 logs reduction in cell viability was observed. When we combined blue light with streptomycin, even under the lowest concentration, 1/8 of MIC of the streptomycin. So over 6 logs reduction in the bacterial viability was achieved, indicating more than 4 logs potentiation by the combination therapy. And we are also investigating the combination of blue light with other antimicrobials, for example, medicinal plants. And this slide shows a synergistic effect between antimicrobial blue light and this is, oh, sorry about that. And the quinine is anti-malarial drug. So from the results, we can see that when the bacterial cells Acinetobacter were exposed to quinine alone at a concentration of 1 milligram per ml, no viability change was observed. And when the bacterial cells were exposed to blue light alone at exposure of 54 joules per centimeter, about 1.04 logs reduction was observed. However, when we combined blue light and under quinine, 8.9 logs reduction was achieved, indicating more than 7 logs potentiation of bacterial killing by the combination therapy. This slide shows the synergistic effect between blue light and essential oil. Essential oil for the inactivation of the Pseudomonas. So when the Pseudomonas cells were exposed to the essential to the oregano oil alone, no viability change was observed during the course of the experiment. To blue light alone at exposure of 50 joules per centimeter, 1.12 logs reduction was observed. So when we combined blue light with oregano oil, 8.09 logs reduction in the Pseudomonas viability was achieved, indicating approximately 7 logs potentiation by the combination therapy. So we are also investigating blue light activation of other important pathogens. For example, Neisseria gonorrhea. Neisseria gonorrhea is the causative pathogen of the infection gonorrhea. So the spread of antibiotic resistance in Neisseria gonorrhea has raised a global concern. So the USA CDC has now flagged the drug-resistant Neisseria gonorrhea as one of the urgent threats in the United States. So, and our preliminary studies showed that Neisseria gonorrhea is highly susceptible to blue light activation. So blue light could be an alternative approach for the treatment of this infection. So we're also investigating blue light activation of Moraxella catarrhus, which is a causative pathogen of the ear infection or otitis media. And we have found that Moraxella is also highly susceptible to blue light activation. And right now we are developing an optical waveguide that can deliver light into the mid-ear. We're also interested in using blue light for the treatment of wound infections in maritime environment. And as a major causative messaging, one of the major causative messaging is Vibrio renificus. And our preliminary studies show that the Vibrio is also very susceptible to blue light activation. And we have established a mouse model of Vibrio infections by using luminescent strain of Vibrio for the next step of in vivo study. So we are also interested in blue light treatment for implant-related infections. Urinary tract infections. In treating urinary tract infections, light will be delivered by using optical fiber diffuser. So blue light treatment of eye infection, keratitis. And we are now developing an optical waveguide that can deliver light to the retina with minimal exposure to the retina. Blue light treatment for the left ventricular device driveline infections. The major causative species of this infection, Staphylococcus, as we showed previously, and Staphylococcus could be readily killed by blue light. So biofilm-based ear tube infections, type of panostomy tube infection, and the major causative pathogen is also Staphylococcus. So we are developing optical tube by integrating the clinical used ear tube with the light delivery delivery sheet for the treatment and prevention of this ear tube infection. So for all the light-based therapeutics and also diagnosis, one bottleneck is limited light penetration in human tissue. So to counteract this problem, so we have developed optical lens microneedle array that can deliver light interstitially in the human tissue. This device is composed of two pieces. One is a micro lens array and the other microneedle array. The rule of the micro lens array is to focus incoming light and then transport to the microneedle array. The microneedle array deliver light interstitially to the human tissue. So conclusions: blue light selectively inactivates microbial cells over the host cells, and the development of light resistance by microbial cells is unlikely. The blue light is also non-genotoxic to the host cell under the light exposure for killing bacteria. And in summary, blue light is potentially a viable strategy in treating localized infection. In the future studies will include to elucidate the mechanism action of antimicrobial blue light at the molecular level and to explore the combination therapies by using blue light and other antimicrobials to develop a new light delivery techniques for enhanced blue light distribution in human tissues, and eventually to pursue clinical trials. So these are the personnel who have contributed to the blue light project. So the blue light research in my lab has been funded by the NIH, US Department of Defense, and private foundations. So I will be glad to take any questions.
Okay. Thank you so much, Professor Tang Hondai. Actually, we already have 3 questions. The first question and the second question from Professor Suryani Dia Astuti. She also attended your international conference last year, the SPA Photonic West in USA. His first question: for the case of biofilm inactivation by antibiotic-resistant bacteria, is the use of endogenous porphyrin more effective, or is it necessary to add an exogenous photosensitizer? That is for her first question. And the second one, how is the mechanism for inactivation in biofilms, because bacteria are protected by an extracellular polymeric substance layer? Thank you, Prof.
Sure. I think the first question is which is effective, right? Endogenous photosensitizer and exogenous photosensitizer, right? We have to say in many cases, like PDT, by using exogenous photosensitizer, are usually more effective, but not always. Than blue light, like blue light is not involved in using exogenous photosensitizer. But the advantage of blue light is we don't have, so we use blue light, we don't have the problem of drug delivery. But drug delivery sometimes is many times is an issue. Yeah, because the challenge is to introduce like exogenous photosensitizer to certain microbial cells. Sometimes it's a challenge. Yeah. The second question is the PDT or light treatment of biofilm. I would say that light can penetrate biofilm better than photosensitizer. Because I know the biofilm could prevent the matrix of extracellular polymeric substance. It could prevent the penetration of antibiotics or photosensitizer into biofilms. A light can penetrate, I think, deeper than.
Okay. Thank you so much, Prof. And on behalf of Prof. Suryani, I would like to send her gratitude and her appreciation for you due to your kindness and willingness to join our webinar and sharing abundant knowledge related to BDT. Thank you. And the third question from Andika Kristianto, he is a student in Department of Physics, Universitas Airlangga. You mentioned about the blue light. Can this blue light hit the healthy cells? If not, what is the mechanism to differentiate between healthy and unhealthy cells? What is your opinion about that, Prof?
So I think it depends on the concentration of endogenous photosensitized like porphyrin. As I showed in my talk, the concentrations of endogenous porphyrins in the host cell human cells are hundreds of times lower than those in the blue light sensitive microbial cells. And I also showed the data about selectivity of blue light killing of microbial cells over the host cells.
Okay, thank you so much, Prof. Dear participant, if you have some question, you can just write down. I have one question, Prof. Actually, if we face some kind of bacteria, we know that each bacteria has a own characteristic. How we know that for this kind of bacteria, some kind of light will be suitable to kill those biofilm or not? Or how we can optimize the condition about the energy layer, the density, energy, etc. Thank you, Prof.
Yeah, I think this is a good question. We have to test. We have to test there to optimize for different maybe different species, different strain. We have to test there.
Okay. Question from the audience. We have about 7 minutes before we continue to the speakers. You can raise hand and our IT team will unmute your microphone and you can ask. Okay, Rari Muhammad raise hand. Please IT team to unmute his microphone. Please, Rari.
Yes, it's very honorable to me for this research about this antimicrobial using a light. The simple question: why use a light? Why for the antimicrobial use a light? For what the future about for the antibiotic? What the future of antibiotic if we use about antimicrobial blue light? And I heard about the nanoparticle used to the antimicrobial. It's for my friend Richard, but it is same between nanoparticle substance in the antimicrobial and the immediately blue light. That's my question.
Okay.
I'm not sure if I'm following you. So I asking about the difference between blue light and nanoparticles, right? Is this your question?
Is that your question, Rari? The relation between blue light. What
in
exactly
terms
is
of
the
mechanism
point?
action?
I repeat.
Okay.
I repeat.
You can tell in
In this
Indonesian.
case,
okay.
Maaf.
Yeah,
Dalam
so
kasus
nanotechnology
ini,
has been used widely in antimicrobial purposes. I know.
Okay.
So I'm not sure if what is your question. So I asking the difference between regarding the mechanism action of antimicrobial blue light and nanoparticles. Is this your question?
Is that your question, Rari? The mechanism of the blue light in antimicrobial application?
Saya ulang lagi.
Okay.
Mungkin pertanyaanku lebih ke gini, tentang ablasi nanopartikel hasil ablasi laser yang digunakan untuk antimikrobial sama antimikrobial sinar biru. Terus kemudian masa depan dari antibiotik itu sendiri, dan juga mengapa memakai cahaya untuk antimikrobial langsung gitu mungkin.
Okay, Prof. I would like to try to translate what he means. Actually, he want to ask: is there any relation, the concept of antimicrobial mechanism with kind of like nanomaterial, some like NGPS, like alumina, that is nanoparticle that also can be put together to increase or to enhance the performance of antimicrobial. And the second one, he asks about why we have to use the light, the blue light. Is there anything, something like that, Prof?
Yeah, sure. Yeah. So first, first the question is about the nanoparticle. I know nanoparticles has been used a lot in antimicrobial application for enhancing the drug delivery. I'm not expert in this area.
Okay.
So the second question, why we use blue light, not other colors, right?
Yes.
This is because peak absorption of endogenous porphyrin is at like 4 or 5 nanometer wavelengths. So blue light region.
Oh, okay. Okay, dear audience, for now, I think we already, the time is up. And if you have some question, we will collect together later and we'll ask directly to Professor Tian Hong. And for the last, thank you so much, Prof, for your attending. And this is a very amazing talk and fruitful discussion. If you are allowed, can you give us your PPT or your material presentation so we can use it as our reference to do some research or to learn more about that. And actually, there is one thing I would like to say that I hope or we hope we can collaborate again in the near future. That there is 3 programs that actually Universitas Airlangga really want to collaborate with you and other speakers, like Dekota program. Especially, we invite some academic lecturer from foreign country to give us a lecture in our particular courses. And the second one is academic peer list. It's kind of like program that we collaborate, such in this webinar, in other research collaboration, etc. So based on your expertise, we wish you are willing to be one our academic peer list. And also the third one is a young professor. I hope in the near future we can collaborate again. And finally, we have come to an end section of our second speaker, Professor Tian Hong. Thank you so much. You are allowed to, if you want to leave, Prof, but if you want to stay, thank you so much. And
Thank you.
Please give Professor Tian Hong Dai a big applause.
Thanks.
See you then, Prof. Thank you so much.
Thank you. Bye.
Yes, bye. Thank you so much. Okay, that's all for the session. The third speaker will be guided by Professor Suhariningsih. For your information, Professor Suhariningsih is the senior lecturer at Physics Department, Universitas Airlangga. She was part of medical physics and biophysics laboratory, and she is currently doing research on bioelectrical and biomodulation for medical acupuncture application. Ladies and gentlemen, thank you for your patience to stay on during this webinar. I'm sorry if I have mistaken some title, degree, or some word. Thank you so much. And Prof. Suhariningsih, the time is yours. Thank you.
Thank you, Ms. Nurul Fitriah, MSc. Assalamualaikum warahmatullahi wabarakatuh. Good evening to all participants. Thank you for being here this evening. For the third speaker, Your Excellency, Professor Douglas Pfeiffer, MS, DAPR, FACR, FAAPM, Medical Physicist, Radiation Safety Officer, Boulder Community Health, and also University of California, Westminster, California, USA, who have magnificent record both in academic field and medical practitioner field as medical physicists. And today, we would like to give a lecture on current topic of radio diagnostic. I think before he start, let me read her brief curriculum vitae. He got his bachelor degree from University of California, Davis at 1985 and continued his master degree at the same university at 1989. He got his certification from American Board of Radiology, Diagnostic Radiological Physics at 1993. He involved in so many committee membership with some prestigious position. Currently serving on the board of director, and also has many association membership, namely at American Association of Physicists in Medicine, American College of Radiology, Radiological Society of North America, American National Standard Institute, American Institute of Physics. He also delivered abundance of talk and lectures. In publication, Professor Paper already has 42 its index. Excellence. Please join me in welcoming Professor Douglas Paper to give a speech. Douglas, time yours. Professor Douglas, the time.
Yes, thank you very much. I'm trying to share my screen.
Yes, thank you.
Okay. Do you see my talk now?
Yes. Oh, no. It's still there. Yes, I think that's okay.
Yes, you should see my talk now. Very good. Thank you very much. It's a pleasure to join you this evening. Thank you for the invitation. It's very much an honor to be able to speak with you this evening. I am going to be speaking on a project that I have been working with the International Atomic Energy Agency on for remote and automated quality control for diagnostic and mammographic facilities. Patricia Mora, one of the my companions on the committee, helped me with this talk, and so I wanted to give appropriate thanks to her for the help that she gave in putting this talk together. Right now, there is a global lack of medical physicists. This is especially true in diagnostic imaging, where the regulations tend not to be quite as stringent as they are in radiotherapy. When we are working with the IAEA, they use a phrase called clinically qualified medical physicist, which is a designation of training and experience that a physicist should have to be termed clinically qualified. Partially because of the lack of medical physicists and partially because of a lack of understanding or a lack of realization of the importance of quality control, implementation of regular QC is poor around the world in both developing and developed countries. For radiographic work, regular quality control is very uncommon. Most regulations are not sufficient to require regular quality control. They may require annual testing of X-ray equipment, but do not necessarily require regular quality control. Along with this, technology is becoming more complex, meaning that the failure modes are different than they were in when film screen systems were the most common. And the way that they fail can be much more subtle. Digital equipment has artifacts and ways of failing that can be harder to pick up. So because of all of these, quality control is very, very important to have. I did a little bit of research on what the situation is in Indonesia right now. This is based on a paper that came out in 2015 entitled Medical Physics in Indonesia, Current Status and Plans. And they found in their paper that diagnostic radiology lacks medical physics infrastructure, that there is a widespread need for medical physicists that is increasing faster than the availability of those medical physicists. There is a lack of measurement tools and devices that makes it difficult to have good medical physics support. And there are efforts to improve the medical physics situation. Particularly in this paper, they mentioned the University of Indonesia in the physics department. They are striving to fill the need for medical physicists, but there is at this time not adequate medical physics support in Indonesia, according to this paper. I wanted to start off with a brief review of what quality control is. Sometimes we take things for granted, and I thought a review might be not out of place. So quality control is a series of continuous processes. It's not isolated evaluations. It means that you're doing it on a regular basis. This involves system performance evaluation, image quality evaluation, analysis of image rejection rates, and corrective actions. The project that I'm going to be speaking about addresses three of these: system performance evaluation, image quality, and corrective actions. That's another point about the quality control that we do on radiographic equipment. During our annual testing, very often it is set up so that we're testing according to regulations, which often do not get into image quality. And image quality is obviously central to what we do. And so we need to add an image quality component to the testing that we do. What is not quality control? Regulatory inspections, those things that the regulatory agencies come in and do on a regular basis. Again, they are looking at regulatory compliance and not necessarily image quality. Conformance testing is important. It's vital to ensure that equipment is installed properly and is performing according to manufacturer specifications, but that only gives you one view of the equipment upon installation. After that, you need to have continuous testing to ensure that it maintains that performance. When something goes wrong, we do troubleshooting on it. This obviously is not quality control because it's a one-time thing done only when there is a problem. Quality control is intended to pick up problems before they become clinically relevant. It's similar with testing following service or sporadic testing for other reasons. These are not regular quality control. Here's an example of why quality control is necessary. If you do regular inspections on it, you may have one data point as shown here on the one green point there. Annual performance testing, you may find that the system is in control as shown in the left graph in the middle and each time during the year, and so you think that the equipment is performing properly. But if you look down below that in the third chart in the first column, you can see that the equipment was definitely out of control for most of the year, and it just happened to have cycled back into control when we did our annual testing. This is why quality control is so important. So as I said, many areas of the world, medical physics support is minimal or non-existent. Many facilities have little or no guidance to implement a quality assurance program. Because of the lack of medical physics support, imaging devices can go their entire useful lives without ever being tested. It depends on what the specific regulations are around that in that country, but some countries have minimal regulatory requirements, and therefore some devices can go for their entire life without ever being tested. Quality control functions do not evaluate whether a given image is actually of adequate diagnostic quality. Quality control ensures that a system is performing consistently, but we also need to ensure that the image quality is adequate, that it is giving the radiologists the information that they need to make a diagnosis. Without all of this, you can get inadequate patient care and excessive radiation exposure. And this has been demonstrated in a number of publications, one of which is the experience with the United States Mammography Quality Standards Act, in which it was shown that, has been shown by several publications, that both image quality has improved and doses decreased since the implementation of that program, requiring weekly quality control testing of all of the mammography equipment in the United States. Because of this situation, the Scientific Committee of the International Atomic Energy World Health Organization network of secondary standards and dosimetry laboratories requested that the IAEA take on a project. And this project was entitled Implementation of a Remote and Automated Quality Control Program for Radiography and Mammography. Under this program, it is intended that one clinically qualified medical physicist can provide support for multiple facilities and ensure consistent performance with fewer site visits. The intent of the project was to cover both radiography and mammography. It needs to be both simple and economical, and provide a quality assessment with quantitative metrics. Simple spatial resolution, bar patterns, and low contrast tests are very qualitative, that they depend on the a decision by the observers to whether the image quality is adequate or not. While this is an important step in quality control and quality assurance, it is not good for regular quality control testing, as you may get different answers depending on the mood of the person who is doing the observing. So what the committee came up with was recognizing that modern technologies allow us to exploit the advantages of computer networks and processing. Digital equipment makes it very easy for us to do very advanced quality control testing with very simple phantoms that I'll be showing you. We did create a very simple and inexpensive test objects for both mammography and radiography. We created automatic image analysis software that will be free from the IAEA. It requires minimal staff time to implement. There is local data collection at the site. The site will perform an image of the phantom, and then this will be uploaded to a centralized system if the facility has that capability. It can also do local or remote analysis depending on the technology that the given facility has. And the data can then be reviewed by a CQMP on a daily or a weekly basis as required. The publication by the IAEA is in process. We expect it to be available in early 2021. It's a new methodology, and this is the table of contents for the publication that's coming out. You can see that it is quite extensive. There's an introduction and a background about quality control, some of the stuff that I have just been presenting. There is a chapter on resources and requirements, those things that a facility will need to have to be able to implement the program. Chapter 3 is testing and reporting. That is the main chapter describing the phantoms, describing the protocol that I'll be describing to you. Chapter 4 is data analysis and requirements. And chapter 5 is finally implementation of it, how a facility would begin doing this. There are also a number of appendices with various important information that helps to amplify or to explain what is in the main portion of the text. This is how the workflow is intended to be taken on in this program. At the facility itself, they will perform the test, do the acquisition of the phantom, or if there is a free screen film system with a film processor, we would do sensitometry on the film processor. I will say that this program is primarily designed for digital equipment. It is able to be implemented with a film screen system, but it does have its greatest impact for systems that are digital and can be sending digital images over networks. The local facility does then inspect the image for the existence of any artifacts. If those are acceptable, if there are no objectionable artifacts, then the workflow continues. If the technologist at the facility recognizes artifacts, these are brought to the attention of the CQMP and they can decide whether the equipment should be used or not. On the left is the automated QC. It can be either done remotely or at the facility. At the facility, they can analyze the test images using the software and then transmit the results to the qualified clinical medical physicist. Or the images can be transmitted by the facility to a central location, and the CQMP then can analyze the images and make decisions on the results of that. In either case, whether the facility does the analysis of the program or of the image, or whether the image is transmitted and the responsible physicist does the analysis, the results need to be then reviewed and verified that the equipment is in control. There is reporting back to the facility whether the equipment is working properly or whether there is some corrective action needed. And then there is documentation made about the QC that was done on that day. The radiography phantom is very, very simple. You can see a drawing of it here on the right of this slide. The target plate, which has the targets on it, the test quality control test objects, is simply a 28 centimeter by 28 centimeter by 5 millimeter sheet of plastic, PMMA. On that is a 5 centimeter by 5 centimeter by 2 millimeter copper square. This is placed so that it is angled 2 to 5 degrees with respect to the edges of the target plate, and this is used for MTF determination, modulation transfer function. There's also a 1 centimeter by 1 centimeter by 4 millimeter aluminum square, and this is used for contrast to noise ratio determination. The main attenuator for the test tool is 10 centimeters by 10 centimeters by 2 millimeters copper. And it can be made of thinner plates stacked together if this is more cost effective. For example, 2 1 millimeter plates may be easier to get hold of. This is letting you see a little bit more closely how the test tool is designed. You can see a layout of how it is meant to be applied clinically. This is a photograph of the test tool. You can see again that it's very simple, just plastic, a square plastic sheet with copper and aluminum affixed to it. The main copper attenuator is affixed to the bottom of the collimator of the X-ray unit. The mammography phantom is very similar to this. in general design. It is made of a 24 by 30 by half centimeter sheet of plastic, PMMA, similar to the radiography one. It has a 5 centimeter by 5 centimeter by 1 millimeter copper square, again angled with respect to the edges of the target plate for MTF determination. It also has a 1 centimeter by 1 centimeter by 2 millimeters aluminum square for contrast to noise ratio determination. The main attenuator for this is a 24 by 30 by 4 centimeters sheet of PMMA, which again may be more cost effectively generated by using two 2 centimeter or 4 1 centimeter sheets of PMMA. Here's a photograph of this installed on a unit. You can see the test plate here in the center of the phantom with the 2 targets on it. And then the main attenuator, the 4 centimeters of PMMA that is resting directly on the detector. For the radiography phantom, we're going to image this using a clinical abdomen technique. If there is no automatic exposure control in the system, we're going to use 80 kVp and 10 MAS. Most importantly is to be consistent with how you image this. If there is automatic exposure control, set that up as you would for a clinical abdomen. For example, 80 kVp using the center cell. If it is possible to transmit the image, it should be transmitted to the CQMP for analysis. The site can perform the analysis locally if necessary, and then just transmit the results to the CQMP. Analysis is performed using software that is called ATIA, Automated Tool for Image Analysis is what ATIA stands for. This is included with the IAEA publication and will be free from the IAEA website. Mammography is very similar. We're going to use a fully automated exposure, auto KV, auto filter if possible. If that is not possible, we're going to set it to 28 kVp molybdenum combination for target filter, 0 density setting. Again, it's most important to be consistent with how this test tool is imaged. And again, we're going to transmit the image if possible, or perform the analysis locally with the software tool that I'll be describing. Some points that are essential for us to remember. The phantom must be positioned consistently every time, not rotated relative to the X-ray field. It's very important for the software to perform correctly that the copper MTF square is angled 3 to 5 degrees with respect to the edge. If it's angled more than that or less than that, the MTF calculation cannot be performed properly. The entire phantom must be imaged. Imaging just a portion of it is not adequate because we're looking for artifacts over the whole field. For film screen and CR system, a single cassette must be identified and used every time. And the same image processing must be used every time. Ideally, we would like to get a flat field or an unprocessed image to do the calculations on. If this is not possible, you can do the analysis with whatever image processing is there, but it makes comparison to other systems very difficult. So ideally, we want to get the raw image, also called a flat field, a QC, or an unprocessed, or a for processing image. Going to talk about the software now, automated tool for image analysis. There are 3 main components of this. One is the screen that does the analysis itself. After the image has been uploaded, it shows you how the analysis is going to be performed. And then there is an analysis looking for artifacts. And I'll be talking about each one of these. The process is you would drag a DICOM image onto this home screen, the upper left, and it will start the analysis there. After the analysis is complete, a comma-separated value file with results is produced. Once again, if you can get raw or for processing images, the data will be much more useful. You could see that there was a number of icons along the edge of the main window here on the left side of the upper left image. This is what each one of those means. I'm not going to read all of these to you, but it does allow for all basic functions, including performing all of the calculations, creating a variance map that I'll be discussing in a little bit, and then saving the data into that CSV file. This is what it looks like on a radiographic image. You can see the image of the copper square and the aluminum square have been identified by the software. It has automatically put regions of interest over the edges of the copper MTF square and the aluminum contrast to noise ratio square. It's put a fourth ROI in the center of the main field of the attenuator for noise power analysis and signal to noise ratio. On the right is what is called the variance map, which allows you to look for artifacts very easily. And I'll be discussing that in a little bit. This is what it looks like in mammography. Again, it's automatically identified the edges of the MTF square. It has an ROI in the center of the main field and an ROI put over the small aluminum square. What is reported by ATIA? First of all, it looks in the DICOM header and pulls out a number of details about the exposure, including the KVP, the MAS, the exposure index if it's reported, the patient exposure, and detector exposure if they are reported. Calculated are signal to noise ratio, the signal difference to noise ratio or contrast to noise ratio, the modulation transfer function in both directions, a normalized noise power spectrum, and a detectability index. I'll be talking about each one of these. Line pair targets and low contrast objects, object visibility tests are subjective and depend on the viewer. Advanced metrics remove this subjectivity, as I discussed earlier. Signal to noise ratio is the background level relative to the background noise. Signal difference to noise ratio is the contrast of an object relative to the noise. Modulation transfer function is the ability of a system to pass spatial frequencies, and it's related to the ability to image fine detail. And the normalized noise power spectrum describes the noise amplitude and texture in a uniform field. The detectability index is a new metric for image quality analysis. It's difficult to directly relate phantom performance to clinical performance. What MTF is needed to be able to see something? What noise level is really acceptable in a clinical environment? And these are all task dependent. Are they looking for a fine fracture or are they looking for a nodule in a lung? These are two very different tasks, and the image quality requirements are different for those two tasks. The detectability index expresses the detectability of objects of some given geometry, object size and shape, and a measure of large area image contrast. It is directly related to a clinical detection task. For example, the detectability of an object of 0.1 millimeters may be the detection of small microcalcifications, whereas the detectability of an object of 0.25 millimeters or larger is the detection of small nodules in a mammogram. It's a rather complicated equation, and I'm not going to go into what all of those terms mean in the D prime equation, but the underlying point is that this is easily calculated in software from the simple tools on the IAEA Phantom, and the ATIA software does do this calculation for us. All of these terms can be measured from the background and the aluminum square and the MTF of the copper square edge. Just wanted to show you how detectability changes with MAS. It would make sense that as MAS is increased, image quality should improve. And you can see in the data that I've presented here, I have percent MAS change starting from a normalized 0, and then decreasing the MAS to the left and increasing the MAS to the right, and the D prime of that microcalcification detectability target. And you can see that as the MAS is increased, that the image quality, that the detectability of that small object, it also increases. On the right is the detectability of a 2 millimeter object, which again is a small nodule that we might be looking for in mammography. Additionally, you can see that the detectability of the larger object increases more quickly than it does with MAS than does the detectability of a microcalcification, which makes sense because we know that low contrast objects are very, very dependent upon noise of the background. So increasing MAS has a great effect on seeing them. Microcalcifications are relatively high contrast and therefore are not as dependent upon MAS as are low contrast objects. And these are demonstrated by the 2 lines. This is a grab of the CSV file that is produced by ATIA. You can see the wealth of information that is in here. There's the modality, the site, the facility, the identification of the specific object. There is the MTF in vertical and horizontal. There's a noise power spectrum. All of the DICOM tags are shown that it looks at. The MTF adds specific frequencies. All of this data is automatically generated by ATIA and put into this file. This was not touched manually at all. This is just exactly how that file is produced. Because it is put into a CSV file, it's very easily read by an Excel spreadsheet. And these have been developed and will also be freely available. They read the CSV file, they compile the data, they plot the results, and they allow for determining if a point is within the action limits. This is an example of that spreadsheet and how it is brought in this case, 8 days worth of data. And you can see how the spreadsheet is brought in. The most important of the data, the MTFs and the D prime, and we'll be plotting those. This is an overview of all of the plots that the software generates for us. You can tell that it goes from everything from the values that are in the DICOM header to the values that are generated by ATIA, and determining with the green and the red lines are showing the control values. We can see over here in the third one down on the right hand side that our MTF was out of control for 1 day before 1 week before it came back in control again. Again, it very simply plots for us information that is in the DICOM header. Ideally, the MAS should be staying very constant for the same object being put in there every time. That's one reason that consistency is so important, that we want to keep an eye on the MAS. If the MAS would start to drift one direction or the other, it could tell us that there's something going wrong with the automatic exposure control system or with the output of the X-ray tube, for example. Here's an example of one of the calculated values. This is the signal to noise ratio. You can see that it is bouncing around, but it is staying in control. Here's the D prime in 4 millimeters. Oops, excuse me. And you can see that it was on the first day I started doing this testing, it was very high and then settled into a well in control evaluation. And this is collected over time. You can get years worth of data into these plots. You can either have them looking at standard deviations. These plots here are looking at ±2 standard deviations, or the software can look at percentage difference. Here are the same plots with action limits of ±15% rather than ±2 standard deviations. And you can see the difference that has in control. It is extremely important for the medical physicist to understand what is implied by picking any specific action limits, how to apply them, and what the implications of that are. If I had stuck with the ±2 standard deviations, which is what I usually do, again, the D prime for 4 millimeters was out of control to start with. With the ±15%, it was in control at the beginning. The variance map allows us to easily visualize artifacts. It gives thumbnail images of the variance of small ROIs in the original image. It enhances the appearance of the artifacts and color codes them. Each color represents a predetermined percentage deviation from the variance in a reference position. And the thumbnails are very small and easily transmitted. Here's an example from mammography of a good image. You can see that the heel effect is visible within this image, but there are no gross artifacts visible. This is the variance map of a radiography image, and you can see that there are some very significant artifacts in this. This is the original image, and yes, you can definitely see the artifacts in this also, and they are objectionable. The difference is that the original image was 7 megabytes versus the variance map, which is just 100 kilobytes. And being able to transfer 100 kilobytes over a limited network is much easier than that 7 megabyte image. Here you can see in a mammography cassette, computed radiography cassette, in July, it looked very good. All that you can see going on is the heel effect. By December of that same year, you can see in the lower right-hand corner that the phosphor is separating from the backing and is causing an artifact in this image. And that will need to be replaced very soon. That's an example of how the variance map can be used. So in conclusion, the IAE program allows a single clinically qualified medical physicist and local technologist to remotely monitor clinical performance of a unit remotely and with minimal time investment per unit. Technologists can be easily trained to acquire the images, and I haven't talked about it, but I mentioned in the introduction that a quality control program ensures that equipment is functioning consistently. It does not tell you if a system is functioning properly. So you have to ensure that the system is optimized before starting this program. The D prime measurements may allow comparison with other systems to determine whether or not a system is functioning properly. There's not a lot of data out there at this point that is research that needs to be done. So hopefully in the future, we'll be able to make that comparison. But for right now, it's really important to make sure that the system is optimized before starting the program. And then the program will ensure that it is maintaining operation at that optimized status over time. Thank you very much, and I'm happy to answer any questions that you may have. I think you're muted.
Hello, sir.
Yes, thank you. Thank you for the presentation, Professor Douglas' paper. Dear all participants, if you have any question, please write down in the Zoom chat or just press the raise hand feature. I will.
Excuse me, I find it very difficult to hear you. Can you speak up a little bit or get closer to the microphone? It's very hard to hear you.
Maybe I will read this answer for you.
Thank you.
Professor Douglas, there are 3 questions for you. The first is, from your point of view, it is clearly understood that Indonesia lacks of infrastructure as well as QC regulation for in supporting the QC process. Can you please kindly give us suggestion on how to improve our QC despite the challenges?
Okay, I'm sorry, it's very difficult for me to hear you, so I'm trying to interpret what the question was. Could you repeat that for me? I'm sorry, I'm just having a very hard time hearing, and I apologize for that. If you could repeat that question for me.
Oh, yes, yes. From your point of view, it is clearly understood that Indonesia lack of infrastructure as well as QC regulation board in supporting the QC process. Can you please kindly give us suggestion of how to improve our QC despite the challenges?
Okay. All that I have to base it on is that one paper, and I was also looking at the regulations, Indonesian's regulations, and from what I could tell from those 2 sources is that there is a lack of medical physicists in Indonesia. You cover a huge area, and it's very difficult to travel to all of these remote facilities that are performing radiography and possibly mammography. And therefore, this program will enable the limited number of medical physicists to be able to give support to the remote facilities by implementing this program. You would build these very simple phantoms for each of the facilities. Each facility would image it and then return the image to the physicists located in probably one of the larger cities. And the quality control analysis would then be performed by the medical physicist. And so in this way, you are expanding the breadth of the coverage of the medical physicists through this program. Does that answer the question?
Yes. Maybe the second question from Desmalia Putri Ardianti Afismi. Would to ask from Professor Douglas, in Indonesia, there are several health facilities that use free DICOM for their system to expertise. How do you think about DICOM being converted to JPEG and then sent via WhatsApp or Telegram or other chat system?
I'm trying to think how best to answer that question.
Yes.
If I'm understanding it correctly, I want to make sure that I'm understanding the question correctly, and I apologize again. Could you repeat that just one more time for me? I'm very sorry.
Yes, yeah, I don't mind. Would you to ask Professor Douglas, in Indonesia, there are several health facilities that use free DICOM for their system to expertise. How do you think about DICOM being converted to JPEG and then sent via WhatsApp or Telegram or other chat system?
Okay, let's see. DICOM is the communication protocol for digital imaging. It is essential for digital imaging. So this program assumes that DICOM is available and that images can be transmitted using the DICOM protocol from one facility to another. Then communication using Telegram or WhatsApp are very simple ways of communicating between the facility and the medical physicist. That is a great use of that technology and would be an excellent way of implementing this program, if I've understood the question correctly.
Yes, thank you. I think it's enough. And then the next question. There are many questions for you, Prof. Class. If sending raw data by email, even if the resolution doesn't decrease, is there still a risk of image quality decrease?
Is there a risk of image quality decrease? There is a risk of image quality decrease over time. The intent of this program is to be able to catch that before it would reach any level that it is clinically visible. That's the whole purpose of a quality control program, is to be able to analyze images and determine if there is a decrease in image quality over time. That is usually it's a slow decrease. The tube output slowly decreases, or the detector is slowly losing its quality, pixels are dying, things like that. Over time, image quality will decrease. This system is intended to be sensitive enough to pick up those changes in image quality so that we can take corrective actions before they become clinically relevant.
I think Desmare Putri, I think it's enough. And then another question from Yusri Isa Uner. Based on your research about PMMA, how can we analyze imaging result? And how we get a sample of mammo cell? I think it's enough, the question, Dr. Klaas.
Let's see, the PMMA that we have looked at has been very consistent. Within the publication, we did not put any requirements on the exact purity of these tools. We wanted to make sure that the materials were readily available in the country. So simple copper sheet, simple aluminum, without any reference to the purity of it can be used. Similarly with the PMMA, in this implementation, the absolute formulation of that PMMA is not central to the performance of the test tool. So you can use whatever PMMA is available in country. Did that answer the question properly?
Yes, maybe there are two again question from Anissa Rahma Fauzia, Afismi DKI Jakarta. I have a question. What is the reason that cause the copper must be rotated for about 3 until 4 degrees?
The copper must be rotated because it has to be far enough from the matrix that there is no aliasing between the edge of the copper and the digital matrix. So if we tried to align it completely with the edge of the test tool, then it would be very close, if not identical to the or it's worse if it's very close to, but not identical to the matrix, to the line of elements in the detector, and you would get bad aliasing that would influence the results. If it's tilted too much, then you're no longer looking truly at vertical and horizontal MTF. So that 3 to 5 degrees is just about the limit of where it can be.
Thank you. I think Anissa Rahman is on. And then there are question from Asabila Sofa. How do we determine what kind of anomaly does a detectability measurement show? Does detectability have standard value or is it compared to the usual finding in practice?
Very good question. There is a lot of research being done on the detectability index in this time. It is fairly new, and so there isn't a whole lot published yet. But within this test tool, we are looking, the detectability diameters have been set up so that they are looking at, in mammography, microcalcifications and small nodules. And in radiography, the smallest one is looking sort of at fractures and like nodules in the liver. Those are the tasks that the specific detectability diameters have been selected for. As we have more research, we'll be able to reprogram and look for whatever is important for a particular research interest. For example, maybe we want to be looking at a ground glass appearance in the lungs for COVID, for example. Once we have the research done, we would learn what D prime diameters is appropriate for that particular pathology. And the work to get that is very difficult because they need to work with radiologists using hundreds of images. And I apologize, I don't know the details of how that research is done. I've not been involved in that specific research myself, but it is trying to relate that specific calculation to the visibility within a clinical image. And the research needs to be done for getting that for all of the pathologies that we may want to look at. And there are researchers working on that at this time. So right now within the test tool, we're looking at nodules and microcalcifications or fractures.
Thank you, Professor Douglas. I think it's not necessary to summarize this presentation. The audience is allowed to summarize. I think we already, the time is enough maybe. And last but not least, thank you so much, Professor Douglas Paver, for sharing us abundant and useful knowledge related to current issue at radio diagnostic. I hope we can continue our collaboration in near future. Professor Douglas, we do have some program which can be used as our collaboration platform, such as Dakota program and academic parallels. We want to collaborate with various parties for research group in order to produce publication in reputable international journal that can also produce competent medical physicists. And the last, the point is we need your support in the future to strengthen up our network and collaboration. Thanks a lot again, and you are alert and you won't leave this webinar if you want to leave this webinar.
Thank you very
so
much. It's been a
Professor Douglas Paver.
Thank you very much. It's been a pleasure and be honored to work with you in the future in whatever capacity we can.
Yes.
Thank you.
Thank you.
Have a good evening.
Next, the last speaker is Professor Suryani Tiah Astuti, who is giving the presentation title is Current Research of Physics for Medical Application in Department of Physics, Universitas Airlangga. First, I will read the curriculum vitae as below. Suryani Diah Astuti was born on the 4th of August 1969. Her postgraduate studies in physics at the Universitas Airlangga and received her doctoral degree in 2011. Currently, she is a professor at Department of Physics, Faculty of Science and Technology, Universitas Airlangga. She has supervised quite few postgraduate students for doctoral degree and Master of Technology. Research topic including antimicrobial photodynamic inactivation, photonic medical device therapy and diagnosis, in electronic nose for dental and mouth disease food quality, ozone technology for microbial infection therapy and quality of medicinal ingredient, radio diagnostic and radiotherapy. For professional association membership, namely Physics Society of Indonesia and Medical Physicists Association of Indonesia. And she has some patent, 10 granted and 2 registered, 2 brand patent, marketing authorization for dental leisure. Please welcome Prof. Suryani. The time is yours.
Please unmute your microphone, Prof. Suryani.
I'm sorry. Okay, I'm sorry. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. Hopefully all of you always healthy and keep enthusiastic about the participating in this webinar.
Too small.
Okay.
It's too low. Your
I want share my PPT. Okay.
Kecil banget ya suaranya.
Okay. I'm sorry. I have to.
Prof. Suryani, you can start your presentation.
Yes, yes. Okay, I want to slideshow. I will share Okay, this is the outline of our PPT as the research group in Department of Physics, Airlangga University. This is many research group in Department of Physics. And okay, this is the position of Airlangga University is in Surabaya city. Airlangga University is located in the city of Surabaya, East Java province. That is about 14 to 16,000 kilometers for our speaker. If the plane takes about 15 to 18 hours, so very far The time in Surabaya is 12 to 14 hours different from America. So this webinar is held at night, and in America in the morning. So I want to thank you very much to our honorable speaker who would like to wake up early to share their latest research. So this is Airlangga University. We have 3 campus in Airlangga University. Campus A for medicine and dentistry, Campus B for social science, and Campus C for management office. And this is Facultas Science and Technology, the Department of Physics in the Faculty of Science and Technology. So according the history of the formation of physics study program at Airlangga University, it aimed to support medical application. So much of the research in the physics department leads to medical application. I am Suryani Dia Astuti from Biophysics and Medical Physics Research Center. My first research is a photodynamic therapy, like Professor Tian Hongdai. PDT is a therapeutic modality that utilizes light source, photosensitizing agents, and oxygen to produce radical oxygen species, or ROS, product that kills the microbes. The effectiveness of the photosensitization process depends on the suitability of the light wavelength spectrum with the photosensitizer absorption spectrum. As in this research, we explore about a physical aspect of PDT, photosensitizer and PDT, that is organic, metal, and drug, antimicrobial PDT, and PDT for cancer, in vitro and in vivo research, clinical trial, and epidemic equipment. So we collaborate with Denny Arifianto from vocational and dentistry with Prof. Ernie and Prof. Abdurrahman and Dr. Ida Kusumawati for exploring the photosensitizer. Organic photosensitizer is a light-sensitive substance that are used to absorb light energy, producing various reactive oxygen species to kill the microbes. There are many photosensitizers, included endogenous photosensitizer like porphyrins, and exogenous photosensitizer that are added from outside to increase the absorption of light energy. We isolate chlorophyll as exogenous photosensitizer from curcumin extract, chlorophyll from spirulina, chlorella, katok leaves, and papaya leaves to increase the antimicrobial effectiveness in photodynamic therapy. And that is the nanophotosensitizer. We also synthesize nanophotosensitizer from medicinal ingredients such as doxycycline. Doxycycline is an organic chemical compound that are capable of killing or inhibiting bacterial growth. Has absorption about 380 to 780 nanometer with a peak of 430 nanometer. The silver nanoparticle has absorption spectrum in visible light. Silver nanoparticle can produce toxicity like ROS and kill the bacteria. That is the spectrum absorption of silver nanoparticle and nanodoxycycline. We also have innovation product, light source of PDT, like CNC laser diode, and LED magnetic, and BioLED and dental laser. That instrument can produce energy of photon to kill the bacteria in the photodynamic therapy. Then that is the result of in vivo and clinical trial. This is an in vivo research. Result of the in vivo research show that the combination treatment of the doxycycline 0.1% and laser 405% nanometer with energy density 8 joule per centimeter square exposure yielded immunomodulatory effects. The histomorphological analysis that was performed, the measuring of the CEGFE is cemento enamel junction and the alveolar bone, so that the combination of doxycycline and laser therapy exerted healing effect in the rat model of periodontitis. This is the rat model of periodontitis. And the clinical trial that is human with periodontitis disease, the result of clinical studies in the patient with periodontitis with dental laser, that is a blue laser with spectrum 405 nanometer on day 3, shown that the gum gradually normalized. This is the gum and gradually normalized from 3 days.
Oh, wait.
The result of the PGE2 4-level test in the subject saliva shown the decrease in the PGE2 level in the patient saliva, which means that there was a decrease in the level of inflammation in the patient. The first week of the treatment has seen a decrease in redness. The redness is a decrease in the end the gum to become pink. And the second therapy, the redness was getting less and more, and on the third therapy, so a cure. So that is the publication of our paper in the Journal of Laser and Medical Science and Infectious Disease Report, and the Journal of International Dental and Medical Research. That is an international journal. And the downstream innovation product, our research group has also carried out of the downstream of the dental laser innovation product through the innovation funding for higher education Ministry of Research and Higher Education Technology from 2017 to 2018. We collaborated with user partners, namely dentistry, and collaboration with industrial partners, that is PT Sarandi Karya Nugraha. He has produced the dental laser instrument. In addition, the collaboration with industrial partner has resulted in the distribution permit for the product and currently in the process of being registered in the catalog. So we have izin edar in Indonesia. That is the dental laser go-to-market strategy for the downstream innovation product of dental laser. And the second research is a gas array sensor in nose. Our research group is also conducting research on the use gas sensor to build electronic nose system using both PCA and neural network computational analysis. This tool is used to the application of array detection of dental and oral disease based on the odor of bacteria that accumulate in the mouth of cavity. We also apply a nose to characterize of the detection food quality, a bacterial contaminant in food ingredient. So yes, they collaborate with me in the gas array sensor research. Mr. Quatriana, Prof. Quatriana from UGM, is he produced genus to detect the COVID like this. Okay, that is the gas array sensory research result. Yeah. Characterize fresh chicken and chicken meat. This is the contaminated with E. coli bacteria. By using gas sensor array system, we use sensor MQ2, MQ3, MQ7, MQ8, MQ135, and MQ136 to respond signal recorded on the computer and process with principal component analysis method or PCA method. That is the characterized of the PCA method. This is the odor of the bacteria E. coli, and that is the meat and bacteria E. coli, and that is just the meat. So chicken meat sample at various shelf life can be classified well and can distinguish the spoils of the sample. So the PCA loading can show that sensor of MP2 and MP7 the most responsive result to gas changes in the chicken coli and chicken meat. And the third research, our research is plasma discharge or ozone technology. Collaborating with innovation grade recipient from the Airlangga from the Diponegoro University with Prof. Dr. Moh Nur, we conducted research on the utilizing with ozone technology that produce ozone for the application of microbial decontaminant in food on medicinal ingredients. The research state is in vitro on various bacteria and fungi, in vivo on the food and medicinal ingredients, with collaboration pharmacy and biology Airlangga University and Faculty of Fisheries for the fish detects the contaminant in the fish. Okay, the effectiveness of antimicrobial treatment with laser diode, microdoxycycline, nanodoxycycline, and silver nanoparticle ozone treatment and ozone chlorophyll laser treatment, so that ozone chlorophyll laser and nanodoxycycline with laser can kill the bacteria 80%. The effectiveness of nanodoxycycline and ozone combined with chlorophyll and laser is maximal. And that is the publication of our research in the international journal. And our member group of Biophysics and Medical Physics, Professor Suhariningsih, have researched about bioelectric and acupuncture. She researched basic research, what is chi in physics, theoretical study, and applied research is the use of electroacupuncture, electrostimulator acupuncture, AS4, this is the dissertation, to improve the body bioenergy and the prevention of adipogenesis and increase the expression of ST gamma R1 macrophage. And he built diagnosis equipment, acupotentiograph with patent ID, this ID, and bioimpedance meter, and the product of therapy equipment like a laser puncture and electrostimulator. Collaborator with pengobat tradisional medicine from vocational Airlangga University, Universitas Airlangga Hospital, and Dr. Sutomo Hospital. This is the research and publication of Prof. Suhariningsih. He researched the effect of electric field, magnetic field, and infrared ray combination to decrease the blood glucose in the diabetic model of musculus. And our research is a medical physics research about radio diagnostic equipment and radiotherapy equipment collaborate with Mr. Bambang Haris Suhartomo from Dr. Sutomo Hospital and Ahmad Mujamil from Haji Hospital and Prof. Ariando from National University of National University of Singapore and other laboratory in Department of Physics Airlangga University. And Mrs. Nurul Fitriah, she is a junior lecturer in our laboratory. She researched about bioactive coating material by continuous combinatorial slit pulse laser deposition of metal oxide then film for medical application. She collaborated with National University of Singapore, Nanoscience and Nanotechnology Initiative of Singapore. So she published their paper in the Journal of Nano Research. And the biomaterial research group, they research about hard tissue biomaterial and soft tissue material. The hard tissue material is about metal implant coating and hydroxyapatite composite as bone scaffold and hydroxyapatite polymer composite nanofiber as bone scaffold, 3D printing, material injectable for bone healing. And the soft tissue biomaterial is PCL, PLA, HA, HA composite nanofiber as a ligament scaffold and polymer as bone tracing and bone healing. The material collaboration is UGM, Universitas Gadjah Mada, and ITB, Batan, and Dr. Sutomo Hospital. This is the member is Mrs. Aminatun, Dr. Aminatun, Mr. Siswanto, Mrs. Jahid Hikmawati, Mr. Jan Adi, Mr. Joni Ishak, and Dr. Yanti. This is the publication of biomaterial research. And Dr. Prihartini Widyanti has research on soft tissue application. She explored the vascular graft, durameter, tympanic, membrane, and etc. And for hard tissue application is about biodegradable bone screw and facial screw, and other research is a blood bag, membrane dialyzer, wound tracing, surgical suture, anti-CA membrane, and Bugota-Tec for gastroschisis. So, and this is the product of biomaterial, like an alginate powder from sargassum and bovine fleece. This is a hollow fiber PLLA collagen coated chitosan and etc. There are many biomaterial resources that result from their research in the biomaterial. And the research group, biomedical signal and system research group, is research about biomedical engineering. Collaborator is Dr. Rifa Icai from Australia and Ibuku Alit Pawana from Rumah Sakit Dr. Sutomo and Abu Jamil, Ardiansah Syahrom from UTM and Dr. Jan Halsburn from Groningen, Netherlands. And the member is Dr. Riris Rulaning Tias, Dr. Kusnul Ain, Akif Rahmatillah, Osmalina, Rahma, and Alfian. This is the research of about biomedical signal and system, biomedical signal from AMD, ECG, EEG, and ADA to detection system, monitoring system, and assistive and rehabilitation device to biomedical device. And the next research group is instrumentation and computation. That's the member is Dr. Riris Rulaningtyas and Dr. Nuril Ukrowiya, and collaborators is Swinburne University of Technology, Massachusetts Institute of Technology, UTM, USM, NCKU, and the research about skeleton robotic of movement therapy for stroke patient and digital pathology virtual microscope and electric impedance tomography continuous with diffuse optical tomography for breast cancer detection and low dose X-ray and CT scan image analysis. And the Biophotonic Research Center is with staff member Professor Dr. Muhammad Yasin and Professor Dr. Retno Apsari, Heri Trilaksana, Andi Hamim, Yaidan Samian, Supadi, and Mr. Pujianto. And the target product is microfiber machine and AC, amplified spontaneous emission, and compact optical equipment for the future plant research. And the collaborator is PRC from University of Malaya, Malaysia, Laser Center UTM, and ORG, University of Southampton, and Photonic Engineering Lab of University of Malaya, Aston University, and CGCRC Kolkata, India, and Flinders University. Until 2020, more than 2020, more than 170 papers have been published with IC and Scopus index. And the finished research is quantum engineering design, that is the theoretical physics. The member is Fabian Rosidi, Andi Hamim Zaidan, and Arif Wibowo. Research assistant, this is the student that is from other university in Indonesia or in abroad. And then current interest about elucidating biological process with the basic of quantum mechanics and computational methods. And in that case, ester hydrolysis and Alzheimer's disease for drug development, and ester hydrolysis in palm oil purification for the green diesel application, and redox and quenching radical by antioxidant from curcumin and guanidine C for drug development. This is the facility of software like Gaussian, Wolfram Mathematica, Quantum Expresso, cluster computing facility with total about 80 cores and etc. So the collaborator of the Research Center for Quantum Engineering Design is Andri Forosidi. He is prof from National University of Singapore, and Yoshitada Morikawa. He is a professor of theoretical physicist, Osaka University, Japan, and Azizan Ahmad. He is professor for experimental chemist, University Kebangsaan Malaysia. That is the recent publication of Research Center Quantum Engineering Design in the international journal like Molecule, Biochemistry and Molecular Biology Education, KEAHLIAN, and the New Journal of Chemistry. So collaboration will more make use advance and develop. So please, we can collaboration with APC, lecturer, researcher in Indonesia and abroad. Thank you so much.
Yes. Thank you for Prof. Suryani for giving us a very important information. And now I will read some question for you. Yes. The first question is from Rahma Ajeng. Why the utilization of nanophotosensitizer can increase the effectiveness of antimicrobial and photodynamic therapy? And then the second question, what is the role of part of ozone in microbial decontamination in food?
Okay.
Maybe two is you can answer.
Okay,
first.
thank you
Yes.
so much, Prof. Suhadiningsih as a moderator. We know the nanoparticle like silver nanoparticle or nanotoxicity could damage the cell membrane and structure and inhibited the normal breathing process because of the disintegration of cell membrane. And nano size of photosensitizer like silver nanoparticle and nanotoxicity will increase the ability of photosensitizer to absorb light energy due to wider surface that increases the production of ROS or radical oxygen species. That is a radical that will damage cell membranes and cause bacterial cell disease. So that is the toxicity of silver nanoparticle and nanotoxicity can cause kill the bacteria. And the question two, generation of ozone, we use ozone to kill the contaminant of the food, because the generation of ozone can produce hydrogen peroxide that is generating free radical toxic, and that free radical toxic will kill the microbial and the contaminant in the food, plant and medicinal ingredients. So the ozone can combine with laser diode that can increase the effectivity to kill the microbial contaminant. Thank you.
Thank you. And the last question is also from Rahma Ajeng. How the electronic nose works for early detection of oral and dental disease?
Okay. Our research about the sensor array system. The sensor array system is a device that is developed to detect odor and characterize the combination of gas forming the odor, the bacteria on the teeth, and oral cavity is produce a characterized of odor. The concentration of this odor is increasing with increasing member of bacterial population. So that based on the type of odor and concentration, it can be seen the type of disease and how many bacteria can present in the oral cavity. Thank you.
Yes. Thank you for your presentation and your answer. I think it's enough, the time. And from this webinar, we hope that there will be a research group in future, which going to produce more publication in international journal, and graduated competent medical physicists who have medical service in hospital. And to all participants, thank you very much for giving much attention. I will hand over the time to the Master of Ceremony again. Please, Master of Ceremony.
Thank you, Prof. Lin. Thank you for the fruitful discussion. Now we arrive to the final session. Alhamdulillah, praise the Lord, we have come to the end of the event. And thank you for Professor Cheng Bisau, Professor Tian Hongdai, and Professor Douglas. Thank you, you're still here with us, and we hope you can open your video so we can have take a picture together to keep our memories here, if you don't mind. And for all the participants who still join us, please open your video also. Bu Nurul, can you please help me to coordinate the picture taking?
Okay, please switch on your video. I will count from 1 to 3. Be ready in the first page. 1, 2, 3. Cheese. Okay, wait a minute. I have to paste this picture, this screen capture. Okay. Again, 1, 2, 3. Cheese. Okay. Wait a minute. Okay, and I just take the version that only switch on the camera. Okay, this is the second page. 1, 2, 3, cheese. Okay, and the last, the third page, cheese. And we have 17 pages here. I will screen capture later. So just switch on your camera and I will give again to the MC. Please, Miss Kartika.
Okay, thank you, Madam Nurul. Okay, for the final closing, I would like to say many thanks to the speakers, moderators, and participants who have listened attentively to the event from the beginning to the end, especially to our honorable guests with their remarkable insights. Hopefully, a lot of knowledge will be gained to broaden our horizons in the advancement of biophysics and medical physics. On behalf of the committee, we would like to say our apology for any shortcomings and mistakes, whether intentionally or not. Special thanks to our colleague, namely AFISMI member for all over Indonesia, students and lecturers from UNER, Brawijaya, UI, ITB, IPB, ITS, USU, Undip, UNS, UNAS, UNILA, UNSRI, and all of alumni from Philippines, Thailand, and other countries, researchers, hospital team, clinical and medical enthusiasts from all around Indonesia. I'm sorry for not mentioning all due to our time limit. We really appreciate your attendance and enthusiasms. More than 1,000 people registered and more than 500 attended this webinar. And we hope our collaboration will continue to develop in the future. Lastly, we are very grateful for this fruitful discussion. Hope that this event can be routinely held. See you again on another occasion with other interesting topics. Have a nice day, good evening, and goodbye. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. So much, Professor Tian Hong. Thank you, Prof. Douglas. Thank you, Prof. Ruby.
Thank you, everyone.
Thank you, Prof. Ruby. Matur nuwun, Prof.
Thank you so much semuanya. Terima kasih.
Selamat ya Bu Dia, Bu
Prof.
Tuti.
Ruby, Prof. Aulia.
Matur nuwun, Bu Yulia. Terima kasih, Mas Reri. Kamu mau tanya apa tadi? Terima kasih, Bapak Ibu Afismi. Terima kasih, tambah sukses ya.
Terima kasih teman-teman Afismi, Mbak Tia.
Mbak
Halo, Pak Frin.
Terima kasih.
Prof. Agus, terima kasih.
Matur nuwun sudah menunggui kami sampai akhir.
Terima kasih. Assalamualaikum.
Terima kasih Pak Arif.
Ya, sama-sama.
Prof. Ruby.
Matur sembah nuwun.
Semua supportnya.
Halo, Prof. Tia.
Nggih, matur sembah nuwun Pak Kardianto. Ya Allah, sehat Pak Kardianto. Alhamdulillah, udah lama sekali nggak ketemu Pak Kardianto.
Nggih, sehat Bu.
Alhamdulillah, penjenengan sehat juga ya Pak.
Nggih,
Kapan ini
alhamdulillah.
bisa membimbing bareng
Nggih.
lagi Pak? Tidak ada
Insyaallah,
gangguan sama
insyaallah, nggih.
sekali. Ya, nggih. Masih tetap muda Pak Kadianto.
Alhamdulillah, nggih.
Sehat, nggih.
Prof Agus, ayo. Headset. Kapan ITS?
Prof Agus, besok Desember, nggih. ITS ya Prof nggih.
Siap, siap. Mantap, mantap. Ini apa? Kami juga paralel di
Oh, paralel ya Prof, makanya ya ini. Nggih Prof, ini udah siap-siap. Sama-sama malam hari, nggih Prof nggih.
Kalau yang di sebelah kanan ini Krakatau ini.
Oh, Krakatau. Injih Prof, alhamdulillah matur sembah nuwun ini berkenan bergabung dengan kami Prof.
Wah, ini gimana ini Pak Kardianto ini bolo dewe iki.
Lah nggih Pak Kardianto.
Kabare, Cak?
Alhamdulillah sehat, Prof.
Oh, suwi awake dhewe gak ketemu ya.
Nggih.
Saya mohon izin, Prof Rin, Prof.
Nggih, matur sembah nuwun Prof Agus. Nggih.
Matur nuwun Prof Ruby.
Matur sembah nuwun, nggih. Nggih, semangat Prof. Matur sembah nuwun Mbak-mbak, Mas-mas dari Afismi, Bapak Ibu sekalian, sembah nuwun atas kehadirannya, atas kerjasamanya. Mohon maaf jika ada kekurangan kekilafan, nggih, Mas dan Mbak semuanya.
Sami-sami.
Sama-sama Bu, sama-sama Prof.
Nggih, matur sembah nuwun. Mas Aat sehat, Mas?
Alhamdulillah Prof. Prof, iya sehat.
Nggih, alhamdulillah sehat. Ini sudah belum? Berhasil belum?
Kurang sedikit Prof, minta doanya kurang sedikit.
Mudah-mudahan sehat ya, babynya sehat semuanya.
Alhamdulillah sehat. Sudah mau
baru kelihatan ganteng lagi.
Alhamdulillah ketemu sama pembimbing lagi, semakin semangat.
Alhamdulillah, ya tetap semangat. Ini sudah selesai diklatnya Mas?
Iya, kurang 2 bulan lagi Prof, insya Allah. Ini sama pihak tim penyelenggara diusahakan sebaik mungkin untuk segera selesai.
Juga di rumah sakit ya, hands on.
Ya sementara ini ya daring-daring seperti itu aja sih Prof. Ya sambil nunggu keadaan. Semoga Prof Dia dan dosen-dosen UNER juga yang lain juga sehat semua.
Alhamdulillah sehat semua Mas. Pokoknya kita saling mendoakan mudah-mudahan semuanya sehat, sukses, ya dalam suatu apa ya Mas ya.
Amin ya Ibu.
Di masa pandemi ini pokoknya semuanya harus jaga kesehatan dengan baik ya.
Amin ya.
Amin.
Matur semuanya.
Prof Retno matur sembah nuwun Prof Retno. Bu Yanti.
Mana?
Ya ini ada Prof Retno.
Nggih Prof, sami-sami.
Bu Yanti matur sembah nuwun Bu Yanti.
Nggih.
Ini monggo kalau ingin berkolaborasi dengan Bu Yanti banyak sekali menghasilkan paper-paper jurnal yang produk-produk bagus-bagus nggih.
Enggak ngerti live ya.
Matur sembah nuwun nggih Bu Yanti udah menunggu sampai selesai.
Nggih, sami-sami Prof.
Ini
matur nuwun juga.
Pak masih ada juga Pak Favor. Thank you so much.
Matur nuwun Pak Fer, Pak Ferdi, Pak Fadli. Mana?
Matur sembah
Bu
nuwun
Yanti,
Pak Fadli.
mana? Bu Yanti. Tadi ada kok, Prof Abdurrahman ya? Ada. Tadi ada Prof Abdurrahman.
Oh, Prof Abdurrahman juga ada nggih. Alhamdulillah. Nggih. Mas Heri, matur nuwun Mas Heri.
Ya, sudah live semua.
Prof Rin dan semuanya.
Nggih.
Prof Dia, Prof Rin, nyuwun pamit rumiyin kula.
Nggih. Pak Kardianto, matur sembah nuwun nggih Pak Kardianto nggih. Alhamdulillah. Nggih, matur sembah nuwun nggih. Panitia Mbak Anu Ajeng, Mbak ini matur nuwun sanget.
Sami-sami, Bu.
Nggih. Alhamdulillah.
Alhamdulillah.
Alhamdulillah akhirnya selesai juga. Tapi masih banyak juga 85 ya. Tadi tinggal tidur paling.
Selamat ya Prof Tuti, Prof Rin.
Sukses.
Ye, barakallah. Saya soalnya double sama ini loh, mempersiapkan PIMNAS nih, PKM.
Oh, nggih. Kapan Bu Yanti berapa yang lolos dari UNER Bu Yanti?
10.
Alhamdulillah. Nggih. Dari TB berapa Bu?